in progress. Assalamu alaikum wa rahmatullah wa barakatuh. Good morning and welcome to all of you to this CME on COVID organized by the Department of Cardiac Anesthesia. As you know that booster doses of So, welcome to all of you to this CME on COVID-19. This being organized by the Department of Cardiothoracic Anesthesia. COVID is still around, as is evidenced by the fact that many countries are thinking of giving a booster dose. So, a CME on COVID is of immense interest even now. Now, I would like to welcome Dr. Faiza. I would like to welcome Dr. Faiza, Assistant Director of NHC, as well as she's the Program Director of OMSB Program for Radiology. We welcome the invited faculty, especially Dr. Kamal Al-Jabri from Kora Hospital, then our own faculty from Royal Hospital, Dr. Khalid. I'm sorry, this thing is missing. So Dr. Khalid, Dr. Khalid Al-Saidi, Dr. Bala Lavati, Dr. Ramanathan, our own Dr. Mohammad Nabi, Mr. Saleh Al-Hati, Judy Chagwani, she is coming in after a little while, or Ishaq Alamri, and Ms. Sama. Thank you very much for agreeing to be with us and share your experiences and expertise, especially how COVID has affected you all. We would like to thank the administration of National Heart Center, Dr. Salim Askari, Dr. Faiza, and Mohammad Al-Hindi for all the guidance and support, and more for the sponsorship that they have provided for this. The e-certificates for the attendance will be sent to you, provided you give us the email IDs. So when you fill in, kindly give us the email IDs so that you don't have any hard copies. It will be all on email. And thank you very much, Umayma, for all the arrangements and for allowing us to, for processing the OMSB accreditation. As you all know, we have 4.5 point CPD point for this meeting, and that's because thanks to Umayma. So with this, I invite Dr. Faiza to inaugurate the scientific session and the academic session.
Assalamualaikum, and good morning, everybody. Since the COVID started a year and a half ago, a wealth of knowledge had developed. 1.5 years ago, we knew nothing about the COVID. How do we handle it? How do we care for our patients? Particularly for us here at the National Health Center, there were many changes in caring for cardiac patients. This subgroup that has special and particular needs. But I think by now that international and local knowledge have developed well. And today the team is going to present us with their expertise and the knowledge in this field. So we thank the whole team, the speakers and the organizers for organizing this seminar. Special thanks to Dr. Madden and Dr. Ranga for facilitating this. We wish you a very fruitful day, and thank you for all. We may start. I'll switch back.
Chairpersons for the first session are Dr. Muhammad Al-Mukheni and Dr. Prashant Kumar Mukherjee. Dr. Muhammad Al-Mukheni is a senior consultant and interventional cardiologist, program director of cardiology fellowship program, and member of Scientific Committee of Arab Board for Internal Medicine and Cardiology, and he is a director of Structural Heart Program. And Prashant Kumar Mukherjee is a senior cardiac anesthesiologist, and he specializes in trances of electrocardiography. I invite both of you to occupy the test.
Good morning, everybody. Thank you very much for inviting me to this session. And the first speaker, Dr. Amal Jabri, is going to talk about the basics of the PCR and basics of the COVID virus and the infection control. Dr. Amal Jabri, she is a consultant microbiologist at her hospital, and she's the director of the microbiology training program for the Oman Medical Specialty Board. She's the director of infection prevention and occupational safety. So, Amal, once again, please, all the speakers, try to remove the mask while you are giving the presentation, because the voice will not be clear.
Assalamu alaikum and good morning, everyone. My name is Dr. Amal Jabri. Thank you for the invitation to talk today about the COVID-19 diagnosis and infection prevention. And we will focus mainly on what clinicians need to know. Actually, as Dr. Faiza mentioned, in the past 1 year and a half, we have learned a lot about a new virus, totally new virus for all of us. And we have been like in touch with the clinicians. We advise them throughout the pandemic. So in today's presentation, I will be I will be actually talking very basic information about the basics and definition of the real-time PCR, which is the gold standard of diagnosis of COVID-19. Then I will be touching on the virology of COVID-19. SARS-CoV-2 is the other name of the COVID-19 virus. And then we will be touching on infection control guidance and a few take-home messages. So if we talk about, of course, during the era of COVID-19, you have heard about real-time PCR or reverse transcriptase polymerase chain reaction. So this is the main and the gold standard in diagnosis of COVID-19. This assay involves nucleic acid amplifications and detection. And this, especially with viruses, it's very small organisms that cannot be detected by usual culture, and the culture usually takes longer time. That's why scientists have come up with a new method, which is the polymerase chain reaction, in order to amplify and make many copies of the viral DNA, and then we are able to detect these viral genomes. So it detects a small amount of viral genome to confirm its presence, but it does not always confirm the presence of infectious virus. So the PCR can detect a living virus or even a dead virus. So it does not really correlate well that there is an active infection. We have to correlate it with the clinical syndrome of the patient and clinical presentation. So we have many viruses. Some of these are RNA, others are DNA virus. And as you know, the COVID-19 or SARS-CoV-2 is RNA virus. So reverse transcription is done for viruses with RNA, as it needs to be copied into complementary DNA before it is amplified. So what is a real-time PCR? As a real-time PCR, it detects at a real, why is it called real-time? Because we are taking real-time pictures from the machine about how much genome in the patient sample. And we get this information by having a fluorescent probes that emit signal when bound to the end product of the PCR. So if the genome of the COVID-19 is present, there will be a fluorescent signal emitted from the sample, and this fluorescent signal will be detected by a camera, and then this results will be interpreted either quantitatively by copies. Unfortunately, in COVID-19, there are no assays which gives you how many copies in this sample. However, we get a semi-quantitative picture by getting a CT value. And I will explain later on my slides what is a CT value means. So in order to increase the specificity of the COVID-19 PCR, we have more than one target that is detected because we have families of coronavirus. We have to be very specific, and I will tell you what targets we aim in COVID-19 PCR. So the process of COVID-19 diagnosis usually starts all of us are very familiar with it. All of us had a swab at least once. It starts with sampling, then inactivation of the sample. Once the sample is activated, we have to get the RNA of the COVID-19 extracted from the human genome or other proteinous material in the sample. Once the RNA is extracted, it's transferred into something called a PCR plate. So this PCR plate usually contains 96 wells. Each well contains a lot of material to help the RNA virus to amplify. First step is that this RNA virus should be converted into complementary DNA so we can detect it and then amplify it and make many copies of that virus. So the amount of virus that is there will help us to find out if the patient is having active infection or past inactive infection. So when do we call this as a positive or negative? See, what we talked about sampling, then deactivation and extraction, then putting all the material in the wells in order for the RNA to amplify, then transferring that into a real-time PCR machine, which is called the thermocycler. And this thermocycler will cycle the RNA to different temperatures in order to facilitate amplification. So once this sample crosses a certain threshold, and we call that a cycle threshold, this is considered positive. So what do you mean by a cycle threshold? And maybe you have heard sometimes the microbiologist in your hospital telling you this is a CT value, low CT value, high CT value. So what is a CT value? The CT value is a cycle threshold. It's a thermal cycle number at which the fluorescent signal exceeds that of the background and thus passes the threshold for positivity. So the higher the genome concentration in the sample, the fluorescence will be detected in the early cycles and hence a lower threshold. So if we talk about it in details, if the sample is if the patient is having too much virus in his sample, it will be easier. He will be amplifying at a very early cycle threshold. He will be amplifying at around 18, 20, maximum 24. But if he has a very little virus, it will take too long for him to amplify. So we'll have amplify only around 40 or higher. So the opposite, as I mentioned, is true. For high CT values, low genome concentration will require more cycles to reach positivity. So it's kind of inverse relationship. When the CT value is high, then the genome is probably very low. When the CT value is low, then the genome is very high. Most PCR assays usually run in 40 cycles. So the maximum cycle threshold in most assays is 40. However, there are other assays which goes up to 44, like Gene Expert and point of care assays. So there is also another term called limit of detection, which is the lowest concentration of the virus that can be reliably and consistently detected by the assay. And this limit of detection is usually variable from one assay to another. And CT values can be used, as I mentioned, as a semi-quantitative method of detection in assays with a standardized linear quantification curve. So if we have a standardized linear quantification curve, then we can rely on the CT values in correlating with the patient clinical condition. CT values of different assays cannot be compared. So if we have something done by PCR in public health compared to a point of care PCR in the hospital, like a Gene Expert, we should not compare the CT values because the limit of detection will be different. So now we will talk about the biological features of SARS-CoV-2, and we will start talking about what is it. It's actually, as we mentioned, it's an RNA virus from the family of the coronavirus. It's mostly droplet transmission. The upper respiratory tract is the main replication site for the SARS-CoV-2. The viral genome consists of 5 major domains: the ORF1A, the over-reading frame 1A, the ORF-AB, and also the RDB gene, the S gene, which is the spike protein gene, the E gene, which is the envelope gene, and the M gene, which is the nuclear gene. So most of the COVID assays, most of the PCR, like the Gene Expert or the CIFID PCR, looks at 2 genes, which is the N and the S, whereas other real-time PCRs looks at 3 genes, for example, N, S, and RD. Others look at N, S, and ORF. So in the market, there are hundreds of BCRs, but most of these BCR will look at these very specific genes for COVID-19 SARS-CoV-2. So what is how is the infection history starts? So interestingly, once the patient is, the person is exposed to the virus, usually the patient or the person can become symptomatic around 7 to 14 days post-exposure. And this is the rationale behind that we usually, after exposure, ask people to quarantine for 14 days, because this is the usual incubation period for COVID-19. However, studies have shown that patients, even before starting to have any symptoms, can start shedding the virus up to 1 week prior to the onset of the symptoms. And this is very interesting. You might also have seen that during the last of the pandemic, the quarantine period sometimes were shortened up to 7 days. And then at day 8, we do a PCR. And if the PCR is free of RNA, we can ask people to resume their work earlier. So if we find out by day 8 that the patient is not having any viral shedding and asymptomatic, he is unlikely to go into the COVID-19, to catch the COVID-19 and start to be symptomatic. So once the patient becomes symptomatic, the viral excretion or the viral shedding maximizes around week 1 of illness, with the maximum amount of virus being shedded in his respiratory tract. And this virus excretion or shedding decreases as we go. And usually most patients will be free of viral excretion by week 6. However, it has been seen that up to 12 weeks of viral excretion have been reported. So, is this viral shedding infectious? This is a very important question. So this is a study where they correlated with the viral RNA copies and with the cell culture. The cell culture is the specific viral culture, and usually if the virus can be cultured, then it is a viable virus and likely to be infectious. So viral culture will not culture a dead virus. So in this study, when they studied the SARS-CoV-2 viral load correlation, they have seen that viral isolation peaked at 4 days from the onset symptoms, as we have seen from the graph, from the pharyngeal swabs. And also RNA PCR peaked at day 10 of symptoms, while live virus isolation reduced significantly from day 8. So after day 8, they were not able to culture the virus in any of the pharyngeal swabs, although their PCR was positive. So this is meaning that this is mostly a dead virus. No isolates were obtained from sample taken after day 8 in spite of ongoing high viral loads by PCR. So this means that active viral replication was only proven in respiratory samples, while also stool were negative. So how is that correlating with the CT values? Because in real life or in real practice, we actually don't have a cell culture to find out if the patient is having still a viable virus. We rely on the PCR. So how can we correlate from the PCR and get enough information to know if the patient is still infectious or not? So virus was isolated up to 20 days in adults with severe COVID. Some of them were immunocompromised. So the study I mentioned earlier were mostly in mild to moderate COVID, where they have seen that no viable culture was cultured beyond 8 days of illness. However, in patients who are immunocompromised, viral isolation were confirmed up to 20 days. So 95% had no viable virus after 15 days, but some of them prolonged viral shedding was there up to 20 days. So most of studies of mild to moderate disease reports up to 10 days of recoverable virus. And this will correlate well when we talk about isolation. Recovered patient can continue, as I mentioned, to have SARS-CoV RNA detected in their upper respiratory specimen for up to 12 weeks after symptoms onset. But this does not mean it's a viable virus. It's mostly prolonged shedding of the virus. So most of them will be negative by 6 weeks, but some patients will continue to have positive PCR test up to 12 weeks from the symptoms onset. Now we will talk about infection control guidance, and most of the infection control guidance has been correlated with the patient symptoms and the cell culture studies which shown the viability of the virus after the onset symptoms. So this is mostly from the CDC guidelines, and our national guidelines are following the same scheme. The CDC guidelines advises on isolation on symptom-based strategy rather than testing-based strategy. As you might have seen, that testing-based strategy, because of the PCR being the only test available and it can give you a positive test up to 12 weeks. So most of the centers or guidelines or international and national are focusing on symptom-based strategy for isolation rather than on test-based strategy. So on symptoms-based strategy, in mild to moderate disease, we advise to isolate only for 10 days from the onset symptoms if the patient have met these criteria: resolution of fever without antibiotics, improvement in other symptoms, excluding cough, and you will find more details in our national guidelines. So only 10 days for mild to moderate disease, and as this is very much correlating with the viral excretion and cell culture results. So for asymptomatic, for example, somebody tested positive for COVID-19, but patient is completely asymptomatic, we again advise to isolate for 10 days from the test date of the positive PCR test. What about if the patient having severe COVID-19? Again, also the CDC guidelines advise that isolation might be extended for 15 to 20 days from the onset of symptoms. For severely immunocompromised who might produce replicating virus beyond 20 days, we have to consider an individualized de-isolation protocol based on ID infection control specialist consult. So for mild to moderate disease, it's a very straightforward 10 days. However, severe COVID-19 disease need to be de-isolated based on infection control ID consult, and some of the national guidelines advise a test-based strategy. Using test-based strategy, meaning that we have to repeat the PCR and confirm negativity for special population, which are the severely immunocompromised patients, cancer patient receiving chemotherapy, patient who received stem cell transplant or solid organ within the first year, HIV patients where their CD4 is less than 200, patient on high dose immunosuppressant as assessed by their clinician should be de-isolated based on a repeat test that confirms negativity rather than based on a symptom approach. And early constitution of transmission-based precaution can be achieved if they are tested and they are negative. So retesting is usually not advised. So if a patient had positive COVID-19, the CDC guidelines do not advise that a test should be repeated within 90 days, meaning 3 months after the documented infection, because reinfection within this period is very, very rare. We assume that after 3 months of the COVID-19 infection, you have enough antibodies to protect you against another infection or reinfection, unless patient develops symptoms after significant exposure. So if I had COVID-19 like 1 month back and I'm exposed now to somebody from my family, I should not be tested unless I develop symptoms. So exposure alone without being symptomatic does not warrant further testing or quarantine within 90 days of the last positive. So I should not quarantine, I should not be retested within these 3 months. And this is the definition of reinfection. So reinfection only happens after 3 months of the documented infection. So we are nearly there, we're reaching the summary. So again, COVID-19 PCR is the gold standard for diagnosis and screening of COVID-19 patients. The CT value, which comes automatically from the PCR machine, is a semi-quantitative indicator of the concentration of the viral genetic material in a patient sample, and it should be interpreted in line with the clinical context and does not reflect infectivity. So you have to correlate with the patient's symptoms, patient having a very low CT value and symptomatic. This is likely to be acute COVID, he should be in isolation. Patient having very high CT value and asymptomatic, this is unlikely to be acute COVID. This is mostly past infection and should not be taken as a COVID, it should be taken as a normal patient indeed. Isolation of replicating virus beyond 8 to 10 days after onset of symptoms is not common unless disease is severe. So the guideline consistent with isolation only for 10 days for immunocompetent, mild, moderate disease, immunocompromised should be individualized approach. Combination of CT value, clinical improvement, and patient characteristic can guide towards predicting the stage of illness the patient in, and therefore guiding decision of the isolation. Using test-based strategy to discontinue isolation is not recommended except in individualized cases. Function is limited to the patients who are at risk of prolonged viral shedding that can remain up to 12 weeks in the specific groups that I mentioned earlier. Thank you very much. I tried to make it very simple, and I am happy to answer any question. Thank you.
I think we'll keep, thank you very much, Dr. Ahmed, for this nice presentation. We'll keep the question at the end after the fourth speaker. The second speaker is Dr. Khalid Saidi. Actually, COVID really changed the landscape of practice from perspective of cardiology worldwide. People moved actually from what's the ideal care to what's acceptable care. And all the novel technologies, and they have been really dormant for a while, because the whole healthcare system was concentrating on COVID. Dr. Khalid graduated from Sultan Qaboos University in 2009. Then he finished his residency in internal medicine, OMSP, in 2014. Then he moved to the United States to his fellowship in cardiology and interventional cardiology. So he came to the department in July 2019. He's going to talk about two parts in his talk. The first one is the cardiovascular manifestation of COVID. And the second part is the impact of the COVID on the cardiovascular services in the National Heart Center. So, Khalid, you can start.
Thank you. Good morning. Do you hear me well? Okay, so I don't have any disclosures relevant to this talk. Now, the objectives, as Dr. Mohammed mentioned, I'm going to talk about various manifestations, cardiovascular manifestations of COVID-19 disease and their implication on outcomes, which is very important for our patients. The other part of my presentation will be about the impact of COVID-19 pandemic on cardiovascular surfaces and the steps taken to mitigate its adverse effect. We're going to talk about this at the global international level, and also locally at our National Heart Center. So cardiovascular manifestations of COVID-19, I will start with introduction. And this is the statistics. This is like the latest. I just put them last night from Google. You can see it claimed the life of 4,100 patients in our countries, and almost 5 million worldwide. The problem, if you see this statistics, is you can easily lose perspective, and you forget about the other important pandemic, which was there before COVID and will continue to exist after COVID. So I'm talking about heart diseases. Okay, so do you hear me now better?
No.
So maybe the problem is now? People at the back, do you hear me? Okay. Okay, so I'm talking about heart diseases. So if you see here, actually heart diseases is the first cause of death in the United States in 2020 while the pandemic is raging. And you see COVID-19 is only the third cause of mortality. And almost the number of deaths due to heart diseases is double the number of deaths due to COVID-19. So this is very important when we talk about cardiovascular health and COVID-19. It's very important to understand. So I'm going to show you a usual case, just run-of-the-mill case that we normally see at National Heart Center during the COVID pandemic. So this is 52-year-old male with past medical history of diabetes and hypertension, admitted to private hospital with COVID pneumonia, had shortness of breath and no chest pain. And this is very important. He was desaturating despite an IV. Blood pressure is stable without any inotropes. He had AKI, he was anuric, and his labs showed troponin of 2,800, which was scaring to them. And they did echo. I don't know whether it's done by a cardiologist or internist maybe, or emergency physician, I'm not sure, but they reported apical akinesis. And then they referred the patient to the ICU team who asked for cardiology input before accepting the patient. And of course, when they told me about the patient, I was almost sure this is not coronary related. This is the ECG. It's like non-specific T-wave inversion, but with this history of apical akinesis, we thought we have to rule it out. So we actually immediately accepted the patient. We realized if we don't accept the patient, this will delay his care. And clearly the patient was very sick and he required to come to Royal Hospital. So just briefly, the approach to troponin is not different with COVID patients than with any other disease condition. So troponin is not a marker of MI, it's actually a marker of injury, myocardial injury. This myocardial injury can be due to MI or it can be due to something else. MI is a clinical diagnosis, it's not just troponin. And this is the usual approach. I like these slides because they show you exactly what you need. So if you have elevated troponin, then this is either static elevation of troponin, not trending. And this is due to chronic myocardial injury. You see that in CKD patients, you see that in advanced cardiomyopathies and so on. If it is trending, going up or down, then this is acute. And then acute can be divided into ischemic and non-ischemic. Non-ischemic, anything else other than ischemia, inflammation, trauma, toxins, you name it. And then acute ischemic myocardial injury is either type 1 MI, this is the ACS, this is the only thing that we should call ACS, or type 2 MI, which is demand oxygen supply demand mismatch. So COVID patients in general, they have either non-ischemic myocardial injury, type 2 MI, or combination of both. They rarely have type 1 myocardial infarction. However, having that said, ACS is more common in COVID patients compared to general population. But most of the troponin elevation is not due to ACS, but due to other insults. So back to our case, patient arrived at Royal Hospital in critical condition. He was intubated immediately. Repeat ECG was normal. We did the bedside echo. There was actually global hypokinesis and EF is 40%. So now we know this is not, and his troponin actually was coming down. So now we are almost certain that this is just part of his severe COVID illness. Actually I had my team already coming to the cath lab and we were ready to accept the patient for just to rule out coronary artery disease. But the patient was unfit for transfer. They couldn't get his saturation above 70s. Unfortunately, this patient died. This is his chest X-ray. And this is just show you that troponin elevation is usually a marker of severe COVID infection. It's not necessarily cause and effect relationship. I will show you some of this concept in the other slide. Now, this is some of the common causes of myocardial injury in patients with COVID-19. Myocarditis, hypoxic injury, stress, tachycardic cardiomyopathy, ischemic injury, various reasons, including microvascular dysfunction, small vessel cardiac vasculitis, endotheliitis, and some, they do have epicardial coronary artery disease, either plaque rupture or stable CAD, but now they have demand ischemia because of their increased demand during COVID infection. And then you have the right heart strain. You see that with pulmonary embolism and ARDS, pneumonia, they can give you this acute cor pulmonale. And then systemic inflammatory response syndrome, the cytokine storm, affecting and injuring the myocardium as well as other organs. This is some of the mechanisms leading to myocardial injury. And you can see down here, this is the type 1 MI. Basically, this is the plaque rupture. But you can get MI from other reasons like hypotension, increased metabolic demand, hypoxia, and so on, leading to oxygen supply demand mismatch. That is the type 2 MI. This is not ACS. And the treatment of this is still treating the underlying cause. Then you have this direct viral myocyte toxicity. This is the myocarditis. And then you have the DIC, microthrombi, vasculitis, vascular endothelial injury. All those mechanisms can give you microvascular dysfunction, leading to myocardial injury. Stress cardiomyopathy is well known with severe illnesses, not just with COVID. And then you have this hyperinflammatory state and cytokine storm. So as I said again, there is one condition which is ACS treatment. You need to give antiplatelet therapy, anticoagulation, and most likely we need to take those patients to the cath lab and fix their coronaries. But there are so many other reasons for troponin elevation that should be treated only by treating the underlying illness, basically managing their COVID. And this is basically, so what we have with COVID patients is this interplay between multiple factors, including ischemic insult, whether it's microthrombosis, whether it's a plaque rupture, and this non-ischemic, all the other reasons for myocardial injury, like cytokine storm, myocarditis, and so on. And then this interplay with comorbidities. Those patients will have usually older patients, diabetic, hypertensive. Some of them, they have established coronary artery disease, heart failure, and so on. All of this leading to the clinical presentation or the cardiovascular manifestation of COVID-19 infection. You see the shock, heart failure, myocarditis, arrhythmias, ACS, cardiomyopathy, fusion, and so on. Now, this is the influence of comorbidities on case fatality rate, and this is comparing multiple coronaviruses, including COVID-19 here. So if you see the overall fatality rate is 2.3%, which is way higher than influenza. So COVID-19, of course, is not influenza, and this is obvious. Luckily, it's better than SARS and MERS. Now, see the effect of comorbidities. Diabetes. They have odd ratio for death of 9 if the patient is diabetic. Compared to influenza, it's nothing. Hypertension, 7.39. Cardiovascular disease, established cardiovascular disease, 13.6. Odd ratio for mortality. Obesity not mentioned here, but we know that it was associated with higher mortality and so on. So then the prevalence and prognosis of myocardial injury in hospitalized patients with COVID, we have prevalence rate of 7 to 28%, depending on which population you are looking at. Are you looking at patients in the ICU, then you are toward 28%. If you are looking at patients in the general medicine ward, it will be close to the 7%. So it's variable depending on which population you are looking at. This is our experience in Oman. We published this article in the Heart Views. And this is basically the cardiovascular manifestations in patients admitted to Royal Hospital, Sultan Qaboos University, and the Nahba Hospital. And this is our findings. We saw cardiac involvement in about 185 patients out of 540 patients, 34.2%. And then mostly raised troponin, about 32%. We have seen some arrhythmias, some myocardial infarction, some drop in ejection fraction. Now, this is not that much because our definition here was like drop up by 20%. And the other thing is that most of those patients don't get echo. And so this is maybe also underestimation. This is the factors predicting death. History of coronary artery disease has odd ratio of almost 2. Significant troponin elevation had an odd ratio of almost 8. This is in our patients, the patient that we are seeing every day. Cardiac involvement has odd ratio of 9. Cardiogenic shock, of course, odd ratio of 35. And that's not surprising. Now, moving on to other studies this is from China. You have the correlation between mortality and death from COVID, patients admitted with COVID. So if the patient has no cardiac injury, their survival rate is almost like 90–95% survival rate. Look at if they have myocardial injury, the survival dropped down to almost 50%. So, but again, as I said, this is not just a cause and effect relationship. No, this is like troponin, myocardial injury is a marker of severe COVID. Here, the interplay with cardiovascular. So if you have a patient with no cardiovascular disease and normal troponin, look at their mortality. It's very low, it's 7.6%. Add to that established coronary artery disease, and you get double mortality, 13.3. This is established cardiovascular disease with no troponin elevation. Troponin is normal. Now, if you have troponin elevation in a patient without established cardiovascular disease, the mortality is high, 37.5%. If you have both, you have a patient with cardiovascular disease, established cardiovascular disease, and elevated troponin, same time, they have a mortality of almost 70%. And this is basically showing you the correlation between level of troponin and mortality. Look at this, if troponin is very high, 91.3%. See, troponin is, I think, the best predictor of mortality in COVID-19. I don't think you have any other test better than troponin to predict mortality. So again, this is a cause and not a cause and effect relationship. It's basically just a marker of severe COVID infection. Now, moving to the, this is a very important topic, which is ACS in COVID-19 patients. Of course, myocardial injury is common, as we said. And as I told you, type 2 MI is more common than type 1. And only minority of patients, basically, they have symptoms and signs suggestive of ACS, not just myocardial injury, but it's an actual ACS. Again, this is more common than the general population, but still not the most common cause for troponin elevation in COVID patient. This relationship between COVID and ACS is not new. We know that from previous studies. This is a meta-analysis showing the relationship between influenza. This is influenza, not COVID. So influenza and acute myocardial infarction. We know that with influenza, with inflammatory surge, we have more ACS, more MI cases. This is showing the protective effect. This is cardiovascular mortality. And basically those two lines showing you survival for patients who received influenza vaccine versus no influenza vaccine. And you see the difference. It's basically similar to our statin or other important secondary prevention medications. ACS in COVID patients is very unique. And this is reported in multiple studies. I'm just showing you one example. This is from Egypt, I think. Yeah. First of all, here in this study, they reported about 30% of their patients with STEMI, ST elevation. They didn't have any obstructive coronary artery disease. And those who did have obstructive coronary artery disease, who did have culprit artery occluded, they have more thrombotic burden than usual. And actually, we have noticed that. In this study, they have seen almost 17% ST elevation, no coronary artery disease, or non-obstructive coronary artery disease. And the most important thing, look at this. Very high mortality rate in those patients, 30%. But it didn't really differ whether those patients had CAD or no CAD. Obstructive or no obstructive coronary disease, their mortality is same, regardless whether you find an occluded artery or the artery is open. This is a case, 46-year-old male with a history of dyslipidemia, presented to our site hospital with inferior STEMI and thrombolized, then developed VF, intubated, ventilated, had PCR test. This is also hospital negative, transferred here for BCI. This is a chest X-ray. We thought it's pulmonary edema, and actually it improved. So it could be pulmonary edema, although it's inferior MI. But anyway, this is his right coronary artery. It's very ectatic, very tight stenosis, distal RCA, and you see layers. This is layers of thrombus here. Now we managed to open this artery. We had a lot of troubles with no reflow. We had to give a lot of vasodilator therapy, but eventually we achieved a reasonable result. Despite this intervention, successful intervention, patient required increasing ventilator and hemodynamic support. We consulted the ID team because he was, everybody thought he had like ventilator-associated pneumonia. Remember, this is PCR test is negative, and this is early in the pandemic. We are still like naive. So we were treating ventilator-associated pneumonia along with the ID team. And then the day after, patient was spiking temperature 39. So we thought, okay, let's repeat COVID PCR test. And of course, it was positive. So patient transferred to COVID ICU. He was discharged after 12 days of admission and seen in the clinic. He was doing well, asymptomatic, echo is okay, just what you would expect with post-MI, regional motion abnormalities. This case, 74-year-old male with diabetes, hypertension, dyslipidemia, presented to us at hospital with STEMI, thrombolized, transferred here for BCI. We did coronary angiogram, revealed triple vessel disease, planned for CABG. Patient waiting for CABG several days, developed COVID infection while waiting. I cannot say for sure, but I'm almost certain this patient didn't come with COVID from home. He had negative PCR test initially. He didn't have any symptoms. This is probably he got it from either one of our healthcare worker who's taking care of the patient, maybe from another patient, maybe from relatives, we don't know. But he got the infection most likely in the hospital. This is his left main is very tight. This patient shouldn't wait that long. But you see this also the circ is full of clots. This is his LAD, very tight lesions. This is his RCA, totally occluded. Very severe disease, patient waiting for CABG. Now surgeons, they cannot take him. So we end up putting a stent. So stented left main to LAD, very good result. Patient went to the ICU. He remained critically ill. And actually he did improve for a while and he left the ICU, but eventually ended up dying in the hospital, unfortunately. And that is not surprising. This is the relationship between in-hospital outcomes of COVID-19 in ST elevation patients. This is from Spain. You see every outcome is worse. This is patients with STEMI and COVID. This is STEMI and no COVID. Mortality, 5.7%, no COVID. With COVID, 23%. You see the heart failure, same. Everything is worse. Even stent thrombosis is worse with less than 1% if no COVID, 3.3% if you have COVID. So COVID makes everything worse. This is NACME, which is the North American MI registry through collaboration of multiple institutions. You see the same thing. This is the mortality rate of patients admitted with MI and COVID. If COVID, 32%. No COVID, this is before COVID, only 6% mortality rate. Huge difference. Of course, the same thing with hospital stay. So utilization of resources, hospital stay is almost double. ICU stay is almost double if you have COVID versus no COVID. 80-year-old female with no past medical history presented to us at hospital with anterior STEMI and COVID-19, underwent successful thrombolysis. Remember, this is 80 years old, and we are always talking about the age, and those patients don't make it. So this patient actually survived COVID and survived MI. He was referred to Royal Hospital for PCI, elective, because he did well. This is his ECG. You see clearly he had anterior infarction. This is his angio, normal. So this patient recanalized. We don't see any obstructive coronary disease. There may be some like minor narrowing here. Maybe this was the culprit, we don't know. We didn't do further imaging to clarify whether there was anything, but this patient recanalizes nicely, and he did well. 80 years old, surviving both COVID and MI. So I thought I will show you a good case at the end, so that you get a little bit of hope. So impact of COVID-19 on cardiovascular surfaces worldwide. Of course, the problem with COVID is that it can kill patients even if they are not infected with it, because they don't receive the care they need. They avoid coming to the hospital because of fear of COVID. They die. Those are the uncounted for death due to COVID. Patient didn't have COVID, but he died because of COVID. We noticed worldwide decline in hospitalization rate by 40% during the pandemic. Are we getting healthier? Of course, no. This is, of course, because of avoidance of medical care and redistribution of healthcare resources. Even emergencies had to deal with a surge of COVID patients, and they have little time to deal with MI, chest pain patients. Look at this data. As the COVID-19 pandemic started, look at the difference in MI presentation, significantly lower in 2020 compared to 2019. We don't have lower MI, we have lower patients coming to the hospital with MI. Same thing here, is exactly the same thing. ACS, MI coming down as the COVID crisis started. But look at the difference between STEMI and non-STEMI. STEMI, because those patients have severe symptoms, they come to the hospital, even with COVID, because severe symptoms, they have to come to the hospital. So you have decrease in STEMI presentation, but not that much. The decrease is very little compared to the decrease in non-STEMI. Non-STEMI symptoms may be not that severe, so they can stay at home and ride the storm. Same thing here. This is from Italy. You see, if you have overall MI reduced, MI admissions reduced by almost 50%. But see the reduction in STEMI is 26% versus reduction in non-STEMI 65% because of the same symptoms, there's difference in symptoms. Here the mortality. So you have decrease in admissions, but you have increase in mortality. So if you look at mortality, 2019 2.8% from MI versus 9.7% in 2020. STEMI is worse. Non-STEMI is again worse, although not clinically significant. What about COVID-19 impact on our service at the National Heart Center? Of course, we have, as you know, we have space displacement, reduction of bed capacity. We moved to the main building. All of our beds were given to COVID ICU, COVID ward. And we had significant staff shortages. People who left, we cannot replace them. People who are getting infected and taking sick leave. And maybe some nurses, technicians, some nurses are helping with the COVID ICUs. Even at some point, we had doctors sent to the COVID ICU. Disruption of supply of essential equipment material. We rely on continuous supply. It's in our profession. This is extremely important. We need to get wires, we need to get balloons and stents. If we have interruption of the supply chain, then we cannot work. So we had significant issues with supply, with all the travel restrictions. Travel restrictions also affected our ability to introduce novel procedures, because those novel procedures, we cannot just buy the device and then figure out how to use it for patients. We needed technical support. We needed proctorship for some sophisticated cases. We couldn't get those during the pandemic. We had delay in patient transfer due to COVID-19 precautions. Now they are calling you with a patient from Rostov, from Seoul, wherever. We can't accept the patient without COVID test. You need a negative COVID test. Impact of the pandemic on BCI. We had, of course, reduction of volume due to bed capacity, decrease in ACS presentation, but still we try to maintain our services. We had about 70 to 80% BCI volume during the pandemic, or despite the pandemic, I would say. We had no interruption of primary BCI service. We discussed whether we should thrombolize those patients instead of providing primary BCI, but eventually we thought primary BCI is better. You remember, if you thrombolize a patient, you will keep that patient in the hospital, occupying bed for at least 5 days to give them heparin and so on. That is not the best option for the patients. The best thing actually is to do BCI in this patient so you can send him home within 48 hours. So because initially there was a confusion worldwide, not just here, of what to do for those patients. Is thrombolysis better than primary PCI during the pandemic? But I think the guidelines were eventually very clear that we should proceed with the primary PCI. We had at least one cath lab running throughout the pandemic. We never stopped cathing patients, at least the urgent cases. And then, of course, we had to review and prioritize all routine PCI procedure at the time when we didn't have enough beds to admit patients. So we had to do this prioritization. We improved bed capacity by increasing same-day discharges. TAVI procedure we had to stop for a while, but then we realized the COVID is going to continue and our AS patient cannot wait. So eventually we resumed usual work with TAVI successfully. We had a little bit of support from our technical team who are we had a technician supporting us. He's living in Lebanon, and we were able to connect with him through virtual communication whenever we need support. Mitral clip, we actually started mitral clip before the pandemic. We had 8 cases done successfully. However, we had to stop because this is a very sophisticated procedure. It requires a lot of technical support, and we are planning to resume soon. And hopefully we'll resume within a month or 2. And this is not unique to us. Even places with, I know places, big centers in the United States who had years of experience with mitral clip, they had to stop during the pandemic because even experienced centers, they still also rely on technical support, and that is difficult during travel restrictions. EB procedures, despite all the challenges, they continued working with minimal interruption. OBD visits, we had to continue running clinics throughout the pandemic. We had our volume, of course, reduced to avoid or minimize exposure for both patients and staff. And we improved the utilization of virtual clinics. And also we tried to eliminate unnecessary visits, increasing discharges from the hospital. If patient, for example, referred to us for care, and this patient seen by cardiologist at another hospital, instead of seeing him in the clinic, we just give him direct appointment for care and get done with it. Instead of seeing him for OBD visit, I think giving him appointment for care. Echo services. Echo is a unique procedure because echo involving a direct face-to-face interaction with the patient for almost 30 minutes to 1 hour if you are going to do full echo. And that's a problem for exposure to our staff and also exposure of the patients, because you never know, maybe your staff is infected. So there are many international guidelines recommended point of care ultrasound as an alternative to routine echocardiography. We try to eliminate all unnecessary requests, and we dedicated 1 echocardiography machine to COVID ICU, so that machine is there all the time. Whenever we need to do echo in the ICU, we use that machine instead of having to clean and clean and clean every time we are using the machine for COVID or non-COVID patients. Consult service, also we continue with some precautions. Good. This is, I think, my last slide. So managing flow of patients during the pandemic. Of course, all patients accepted from outside hospital should have a PCR test regardless of symptoms. If they are positive, they go to the COVID ICU, COVID ward. If they are negative, then they can come to our wards. All patients admitted to CCU should have a negative PCR test. Otherwise, they should go to COVID-19 ICU ward. Private room in ICW was dedicated to COVID-19, either suspected or confirmed cases. And this was very important to have at least 1 room ready. For example, sometimes you have COVID-19 tests sent from the emergency, but we finished the primary PCI and the patient needs to go to a bed now, and we don't have a room. So having this room was very helpful. Take-home messages, acute myocardial injury, and COVID-19 patient is common and indicate worse prognosis. Most cases are non-coronary and non-ischemic myocardial injury, type 2 and myoboth. The pandemic had negative impact in cardiovascular patients, but serious steps were taken to mitigate this adverse effect. I think the question will be left to the end. So I thank you for your attention.
You need to fix the sound system before we start.
That's right. That's right.
Just increase it. No. Fine. Make it on.
I'll fix that.
Does it work?
It's okay.
Continue.
I would like to invite Dr. Alal Awadi. He's a dynamic speaker actually. He's heading the Department of Cardiothoracic Surgery at National Heart Center. He has completed his residency and fellowship training in cardiac surgery at the University of British Columbia, Vancouver. And also he has finished his advanced fellowship in pediatric cardiac surgery from Advocate Children's Hospital in Chicago. He is a fellow of Royal College of Physicians and Surgeons in Canada. He will be speaking on cardiac surgery in COVID era. Dr. Alal, please.
Thank you very much for the kind introduction and the invitation to this forum today. It's always hard to come after a sophisticated cardiologist talk. We surgeons are very simple, actually. So we try to make it simple and stick to the send home messages. Okay. So the talk today is about impact of COVID-19 pandemic on healthcare and cardiac surgery. I'll be talking about three main objectives. So first, the impact of COVID-19 on healthcare services in general and cardiac surgery. I won't go into details that Dr. Khalid talked. I'm taking other sides more related to surgical services and cardiac surgery specifically. Then we'll talk a little bit about the perioperative cardiac surgery consideration in the era of COVID-19. And then we'll finish with a few slides about the controversial topic of ECMO in COVID-19 patients. So the pandemic made us face unprecedented challenges in patient care. COVID-19 utilized all the resources, and we were challenged on day-to-day basis on where we allocate these resources. Almost all elective cardiac surgery operations have been postponed worldwide in order to reduce the transmission and to reallocate the resources adequately. This came with mental toughness for the team and required a lot of emotional stability. Even as cardiac surgeons, we take pride in being mentally tough, emotionally stable. These COVID-19 time were a real challenge to everyone. So when it comes to resource utilization, there are a lot of similarities in terms of the resources required to cover cardiac surgery and the resources required to take care of the COVID-19 patients. This includes, but it's not fully, this includes physicians, staffing basically, physicians, nurses, allied health services, the need for ventilators, the need for ICU beds, we both require ICU beds, the need for continuous or renal replacement treatment, extracorporeal life support, nutrition, vasoactive medications, sedative medications, and blood products. We share these, and where to allocate what was the challenge. After ICU care, cardiac surgery owns the largest number of ventilated beds. Hence, you see, once your ICU is full, the eye will be on cardiac surgery. Then came the principle of canceling surgeries. So the principles to follow was to protect patient, protect the society, and protect the healthcare staff. So protect the patient. How do we protect the patient? We don't want to delay the services that's required. Is the voice correct? Okay, or yeah, okay. So you don't want to delay the services that the patient require, but you don't want to bring an unnecessary patient who can wait and expose him to the COVID-19 exposures that come with in-hospital admissions. You want to protect the society. Similarly, you want to have a timely services for the patients. And you want to protect the healthcare staff. Again, it's a balance between what's urgent, what's needed, and what can be postponed. And for those who can be postponed, for how long? So it was agreed on that emergency and life-threatening cases, we treat them as normal and adopt all the safeguard measures to protect the patient and staff. And that was done. Stop elective cases and consider alternative clinical pathways in appropriate patients. And as my colleagues talked, what's the alternative pathway? We shifted from the optimal care to the what's accepted. Patient requires surgery, but you can get away with PCI, it's less risk, you might consider that. And that's how we went through. When we come to elective cases, this was our day-to-day challenge. So what's an elective cardiac surgery, basically? So when you look at our patient population in general, you have either an acute and severe aortic stenosis patient who's symptomatic, waiting for aortic valve replacement, someone with left main disease, symptomatic, waiting for surgery, triple vessel disease, stable or unstable, again waiting for surgery. Are these really elective? It was tough to define what is elective in cardiac surgery. This was a study that was done internationally in 23 centers across 18 countries. Surgeons from these centers were asked, what is an elective surgery versus a salvage or emergent surgeries? And you can see, they looked at aortic dissection, dilated aorta, triple vessel disease, and patients with paravalvular leak. The consensus was around acute aortic dissection. The majority said those are emergency surgeries. And of course, these are what we agreed on. But look at ascending aorta aneurysm with more than 55 millimeter dilated aorta in non-bicuspid aortic valve patient. Nearly half said these are urgent, while half said these are elective. Ascending aorta, more than 45 millimeter. The majority agreed that these are elective surgeries. Let's go to triple vessel disease. Triple vessel, interestingly, look at how surgeons, and Dr. Mohammed left just now, how surgeons and cardiologists would think. So triple vessel disease with rest chest pain. Half of the surgeons would think these are urgent procedures that can wait till the next available slot, and half would think these are emergency procedures that would need to be taken immediately. Left main without chest pain, the consensus was these are urgent. Few thought it's elective. Stable three vessel disease and paravalvular leak without pulmonary edema, the majority thought these are elective cases that can be waited. When we talk about wait, it's a period between 6 weeks to 3 months. And these require intensive cardiac monitoring. So it adds the burden on the other services rather than the surgical services. In the same study, so across those 23 centers, almost 92% of the participants ceased elective operations during lockdown imposed by the local governments. And a common observation was also reduced number of referrals for both elective and emergency surgeries. And as was pointed by Dr. Khalid, the population did not get any healthier. It was just people who could not reach the hospital services or people who did not want to come to the hospital, basically. This was another guideline that came from the STS. Basically, again, they looked at, again, consensus among the North American surgeons and classified emergent versus urgent versus semi-urgent and elective surgeries. We are close, so similar to what was pointed out in the previous surgery. For emergencies, so that's entry to the operating room within 72 hours. So critical coronary artery disease, critical left main, on balloon pump, severe AI with shock, severe AS with shock, or acute MR with shock. And mind you, definition of emergent in this paper was within 72 hours. And we all know what can happen to those patients if they were left within 72 hours. Urgent, that is done within 1 to 2 weeks. Left main, a high risk with high risk anatomy, a left main or triple vessel disease with high risk anatomy. Severe AI or AS in NYHA class 4, acute MR NYHA class 4, giant thoracic aortic aneurysm was giants, more than 45, more than 55, is to be discussed. The rest were semi-urgent and elective. The impact of surgical cancellation. So this looks at the whole elective surgical cancellation worldwide. And once we cancel surgery, the patient doesn't go home. The patient remains on the wait list. So it was an estimated worldwide backlog of 30 million elective procedures in just 12 weeks. So if you cancel elective surgeries for 12 weeks, you have 30 million patients worldwide waiting. And that will impact your services when you resume the services. And that's what we're facing now. For cardiac surgery, it increases the risk on the patients waiting for surgery, requires close cardiac monitoring by the cardiology team, so that impacts the other services, and also again, crowding of all the backlog patients. And we'll talk about the numbers here, about the effect here in the National Heart Center. Also, in relation to the treatment of cardiac surgery patients and ICU, COVID ICU patients, period of lockdowns, so an absolute decrease in blood donations. This happened in many countries across the world. It happened here in Oman as well. This paper comes from Ontario in Canada and looked at the mortality around the area of the impact of COVID-19 pandemic on cardiac procedures. So there was a significant decrease in referrals and procedures completed by cardiac procedures during the pandemic period, as was pointed out again in the previous talk. The other conclusion was referral during the pandemic was associated with increased all-cause mortality while waiting coronary revascularization. This included both PCI and CABG. Mortality doubled, tripled, and quadrupled in certain areas. Cardiac surgery also, cancellation had an economical impact. So for us, we utilize service, we spend money. In North America, cardiac surgery is a revenue generating service. The more you operate, the more income the hospital gets. So from University of California, they reported losses of over 140 million over 6 academic health centers in a period of 4 months. Across California, the hospitals were reporting an average losses of 20 to 30% per year, and they predicted a net loss of up to 14 billion across about 400 hospitals by the end of 2020. So this, again, had an economical impact on the hospital, on how the hospital run their services, and will the effect will sustain for at least a year or two before they return back to their norm. Other measures were taken around cardiac surgery cancellation, centralized cardiac services. So what happened in the UK, they closed a lot of the cardiac surgery services in many hospitals, and they had few centralized services where all the patients were referred there. Utilization of virtual clinics and telemedicine. This was near revolution in medicine and cardiac surgery. Telemedicine existed for a long time before this. It was not really utilized in surgical services until recently. And then became the concept of resource utilization and reallocation. So we have the resources, how we utilize it, how we allocate it to cardiac surgery versus treatment of COVID-19 patients. Unfortunately, this slide doesn't come. I tried to bring it. I don't know what's wrong. But anyway, so it's a graph that tells you the relationship between the operative risk and expected live years gain versus the amount of resources needed for patient use. And then this graph changes between the area of the early pandemic, during the peak pandemic, or in the late pandemic. So for example, if you have, unfortunately, this doesn't come, and I'm not sure how to bring it, but let's skip it then. Basically, as I said, so an 80 years old with symptomatic AVR, chronic kidney disease, COPD, predicted to spend a long time in the ICU, high mortality. This patient would be given less preference compared to a patient, let's say young patients with stable cerebral disease, whom you can salvage, and he has more years to come. This happened in the early pandemic, in the peak pandemic area period. In the late pandemic period, this patient would be treated and would be given equal opportunity compared to the other patients. So you can see here in the legend, it's basically it's a graph that compares resources available per pandemic level and the resource utilization for the proposed case. And the graph will give you the area of good operative candidate, questionable candidate, and a poor candidate. In NHC here, at the early phases of the pandemic, between April and June 2020, we stopped all the elective procedures. And we continued with the emergency and semi-urgent procedures. And we had a low threshold for canceling procedures, actually. This impacted us significantly, and we learned our lesson really hard. Those whom we canceled came to us as urgent procedures later in May, June, just before we finished June. And we discovered that with the team that whom we spared in the morning, who was not working in the morning, they would continue in the afternoon, come at evening. And we faced all these patients who were on the elective list came with emergency symptoms. So in June 2020, we decided that this strategy should not be followed, and we gradually commenced the cardiac services. And we reached near full capacity in November 2020. By May to mid-July 2021, we came down again to 50 to 75%. June and July were painful months in the country for all the healthcare services. Right now, we'll tell you the numbers. So for the referral systems, there was a reduced trend during the pandemic. And specifically, there was significant waitlist reduction from November 2020 to February 2021. We came down to 40 patients. But then, since then, and the period of between February to August 2021, the waitlists doubled. This was an impact, again, the reduced number of referrals, as we said in the earlier, and the reduction in the capacity that we were faced with during the summer months. So enough about economy and impact. Let's talk a little bit clinical. So perioperative cardiac surgery consideration in the era of COVID-19. Again, as it was mentioned by Dr. Khalid, COVID mortality with no comorbidities is around 1%. With cardiovascular disease, it averages at 10.5%, but it doubles with other comorbidities. And in COVID-19, with myocardial injury, elevated troponin, mortality goes up to 70%, maybe even more. Proposed mechanism, viral myocarditis and myocardial dysfunction secondary to hypoxia, cytokine-mediated systemic inflammation, decreased activity of angiotensin-converting enzyme 2 in the heart. This again was nicely mentioned in the previous talk. So let's talk more about cardiac surgery. Respiratory complication, generally following CABGs, is 4 to 8%. Respiratory complication slows the recovery of a CABG patient. And if complicated with COVID-19, it slows us down even further. Added to that, most of our patients have added comorbidities, hypertension, diabetes, chronic kidney disease, COPDs, that adds to the burden of those patients. Interestingly, again, our surgery is mostly done on bypass. The systemic inflammatory response syndrome generated by the cardiopulmonary bypass is triggered by the same mediators that causes ARDS due to COVID-19. The proposed mediators are human necrosis factor alpha, interleukin 10, and interleukin 16. And if combined together, these can have synergistic effect and causes significant respiratory complications post-operatively. You're faced with 3 scenarios in COVID-19 and cardiac surgery. So you either have a COVID-19 positive patient, or like what we see now more of, we have COVID-19 survivors and more again, COVID-19 negative patients. So for COVID-19 positive patients, I've spent a few slides on this. This was a paper that came from the Lancet in July last year. It's mortality and pulmonary complications in patients undergoing surgery, any surgery, with perioperative SARS-CoV-2 infection, an international cohort study. This looked at the implications of COVID-19 infection on surgical patients. 1,128 COVID-positive patients were included in the study. Out of those, 74% underwent emergency surgeries, any kind of surgery. The 30-day mortality was 24%. And the pulmonary complication was 51%. In cardiac surgery, out of those 1,000 patients, there were 50 patients. The 30-day mortality was 34%. And the respiratory complication was the highest across all surgical specialties, so 94%. You can see why. This is the table. So they looked at all the surgical specialties: breast, cardiac, GI, gynecology, head and neck, hepatobiliary, obstetrics, orthopedics. And you can see the 30-day mortality was high across most of the specialties. The least number were, you had very few patients, so it's not representative. Even in orthopedic patients, mortality was nearly 30%. But if you look at the respiratory complication, the highest among all was the cardiac surgery. In NHC, we had 3 perioperative cardiac surgery COVID-19 infection. Those patients were discovered post-operatively to be COVID-19 positive. And we had 66% mortality in those. 2 patients basically passed away and 1 survived. And the one who survived was a young patient, 30 in his 30s, with infective endocarditis, no other comorbidity, spent a month almost in the ICU, but eventually he went home. The second scenario is COVID-19 survivors coming for cardiac surgery. And we'll encounter more of these patients now. The study shows that myocardial damage happens in up to 27% in patients with COVID-19 with COVID-19 infection. And you can say 27, let's say 1/3 of the patients. Also, pulmonary fibrosis post-ARDS due to COVID-19 is a significant or a serious problem. So in one of these studies, 1 week disease duration in the ICU, rate of pulmonary fibrosis is 4%. If you spend 1 to 3 weeks in the ICU, then it's 24%. If you spend more than 3 weeks in the ICU, the risk of developing pulmonary fibrosis is 61%. Now, the aftermath and implication of all these, myocardial injury, pulmonary fibrosis, impact on recovery, the aftermath and implications is not yet studies, but will be studies, and this will need more evaluation. These are the food for thoughts in the coming months or in the coming years. When it comes to timing for surgery in COVID-19 survivors, it's been accepted, generally speaking, for asymptomatic patients. You wait for 2 weeks and then you can safely operate. In patients who require ICU stay, you wait for up to 12 weeks. Some guidelines suggest 7 weeks, some guidelines less, more, but these are the acceptable numbers for now. And it's always a balance between the recovery phase, what stage of the recovery phase that the patient is in, and the surgical urgency. Assessment of pulmonary reserve is crucial in those patients, and something that we are overlooking maybe in many patients right now, but something that we seriously need to look at. So you evaluate cardiopulmonary function, coagulation status, markers of inflammation, and nutritional status. These are the main things that you look for in COVID-19 survivors coming for cardiac surgery. And for COVID-19 negative patients, it's basically like the pre-COVID era. Those are the normal patients whom we are used to, and they need to be treated as we were used to. Other perioperative measures that are taken during cardiac surgery, this we exhaustively talked about it, is strict patient triage, preoperative testing in some centers. Some centers didn't have the resources. We didn't have the resources for a good period of time, so this was omitted. Self-quarantine prior to elective surgeries for 14 days, 7 days. This was practiced in the UK. Use of PPI among in-hospital staff, mandatory, and then vaccination. And we'll talk a bit about vaccination. From all those, what was proven to be effective for us mainly here was strict patient triaging. Good history taken by the flow managers before the patient is in, strict history and strict triaging taken by the team when they came to the hospital, and strict triaging even after admission. This what saved us, I feel, from all this COVID-19 complications among our talk about cardiac surgery patients, and I'm sure the same applies in the cardiology services. For vaccination, before vaccination, consenting process. So someone who had COVID-19 now coming for cardiac surgery. What do you tell him? Or someone with COVID-19 positive who requires emergency surgery. What do you tell him basically? COVID-19 added another layer of complexity, and it's yet need to be further investigated. There is yet no accepted number or a formula to be given to those patients. Work is being done to include this as a parameter in the Euroscore 2 test or the STS score test. And there are other initiatives taken to have a separate risk scoring system for the implication of COVID-19 going for any surgery, including cardiac surgery and neurosurgery. So no absolute numbers. Generally speaking, what's been agreed on, and that's from my review of the literature, is a young patient coming with no comorbidities who is COVID-19 positive, you give him double the risk. Whatever the Euroscore or the SES risk, you give him double the risk. For patients with comorbidities, you give him 5-fold increased risk that of the original surgery. Now we have more vaccinated people. So for vaccination, the guidelines recommend full vaccination prior to any elective procedures, and at least 1 dose of vaccination prior to time-sensitive elective procedures. But of course, obviously, vaccination status should not factor into emergent surgical procedures. So basically, it's a balance between vaccine versus safe delay of surgery. Mind you, safe delay of surgery is it really safe all the time? Other guidelines about the vaccination before elective cardiac surgery. So administering the vaccine within a few days before surgery is not recommended because it's unlikely that the patient would benefit immunologically, and they may have side effects that mimic infection. Immunity typically begins to develop approximately 10 to 14 days following vaccine administration. So just giving the vaccine a few days before surgery doesn't really help. And the patient should ensure vaccination reactogenicity has resolved and that any adverse risk event is minimal before proceeding with elective cases. This study studied the effect of vaccination on all elective surgical patients, not only cardiac surgery, again, all elective patients. So they looked at nearly 150,000 patients across 1,667 hospitals in 116 countries. And they concluded that vaccination for elective surgery could prevent 1/3 of those deaths, COVID-19 related deaths in those patients. Vaccination after cardiac surgery. So you have an unvaccinated patient, came for cardiac surgery, made it through, and then now, would you vaccinate him in the hospital? Again, the suggested guidelines is you need to have an assurance of resolution of the acute phase of recovery be confirmed prior to vaccine administrations. And suggested criteria is no persistent SIRS marker, no requirement for respiratory support, unremarkable wound healing, no active medical issues, and typical convalescence following surgery. Timing is not concrete. The vaccine does not cause infection, but may cause symptoms that mimic infection. So day 5 or day 7 or day 10, you give the vaccine. If you think the patient is doing well, he develops fever next day. Now, what is this fever? Is it pneumonia? Is it wound infection? Is it related to the vaccine itself? We really don't know. That's why there is no concrete timing, and these are, again, thoughts to be thought about for the future. Of course, administering vaccine post-cardiac surgery should be a shared decision-making between the team, multidisciplinary team, and the patient, based on the clinical status of the patient's recovery, his recovery phase, and the short and long-term benefits for that patient. There were prior vaccination initiatives for hospitalized patients for immunity against other influenza virus. This was studied and it has been successful. And the data suggested that up to 70% of those patients who were vaccinated during hospitalization demonstrated successful immune response and without significant complication. So what we mean is basically, in the previous pandemics, influenza vaccine was given to patients in the post-operative period during admission. And this was not associated with increased rate of fever or symptoms mimicking the infection. However, again, administering the influenza vaccine, it has low rate of fever, for example, compared to the rate of fever post-COVID-19 vaccine. So whether this applies to COVID-19 pandemic vaccination, really there's no answer yet. Another interesting phenomena that can happen after vaccination is vaccine-induced immune thrombocytopenia, VIT. It's a unique complication that is more prevalent with the viral vector type of the vaccination. So we have the viral vector type and the messenger RNA. This is more prevalent in the viral vector type of the vaccination. The etiology is understood to be like heparin-induced thrombotic thrombocytopenia, and it leads to both arterial and venous thrombosis. The implication of this on cardiac surgery is significant. I will not ruin Dr. Ranga's talk, but this is a nice study that came from the Journal of Cardiothoracic and Vascular Anesthesia, looked at the cardiac surgery enhanced recovery programs modified for COVID-19, key steps to preserve resources, manage caseload backlog, and improve patient outcomes. ERAs is known to reduce the impact on the healthcare resources and make more resource utilization available to us. This comes into the picture now when we are facing those long wait lists, the backlog of the patients, and where we need to utilize our resources wisely. Don't look at the table, just look at this. So basically it looks at the intervention, preoperative, intraoperative, and postoperative. It looks at the level of evidence, the expected benefit in COVID-19, the additional cost, impact on workflow, and implementation complexity. And if you just look at the intraoperative measures, you can see basically all the measures have large expected benefit with low implementation complexity and low additional costs. Something to think about, something to implement, have large benefit, low cost, low complexity. And most of them come with either moderate or high level of evidence. If you look at the post-operative measures in ERAs, again, most of the level of evidence is moderate, expected benefit is large, the complexity is more medium, high, medium, but the additional cost is low. So these are the things that we can do now to have a better utilization of our resources. Last few slides on ECMO and COVID-19. ECMO and COVID-19 remains a controversial subject. We're already exhausting our resources. Shall we exhaust them more and salvage the salvageable patients or not? Different debates, different strategies by the different hospitals, but it all comes down to the available resources that we have. A nice paper came from the Columbia University in New York. What they do is priority given for ECMO in younger patients and healthcare workers with no or few comorbidities, and they do no ECPR ECMO for suspected or confirmed COVID-19 patients. This is their criteria. So the criteria for consideration of VA ECMO is a SCAI criteria of C or D. We'll talk about it. A safe score of more than 1 and minimal comorbidities. And they don't put patients with SCAI criteria of E, patients above 60 years of age, patients with severe peripheral vascular disease, those with septic shock as a primary etiology, those with acute stroke, have contraindication to anticoagulation, and end-stage renal failure. And SCAI is the Society of Cardiovascular Angiography and Intervention. They have these stages of cardiogenic shock. So stage C and D is classic cardiogenic shock, and stage D is a deteriorating patient in cardiogenic shock. E is nearly end stage, and stage A and B are at the beginning, so at risk or the beginning of the cardiogenic shock. If the patient is in C or D, then he's a candidate for ECMO in Columbia University, provided that he has no other contraindications. He goes to E, and that's a lost cause. A and B are still not there yet. And then you look at the SAFE score. The SAFE score is the survival after veno-arterial extracorporeal membrane oxygenation scores. This scoring system predicts the survival after putting the patient on ECMO. You can look at it. It looks at the patient comorbidities, age, weight, prior end organ failures, duration of intubation, cardiogenic shock etiology scenarios, and other parameters. So a score of more than one or more, puts the patient as a candidate for VA ECMO in COVID-19, again in the Columbia University. So this is one paper that nicely came in the Annals last year, talked about this issue. And they talked about the experience in New York, basically, with COVID-19. Lots of interesting papers. And if you look across the world, there are many papers that came from UK, US, different places in the US, Australia, Trinidad and Tobago. And when you look at the New York experience, they stopped elective cases for a period of 4 to 6 weeks in cardiac surgery. You look at the Australian experience, they had very limited period when they stopped elective surgeries, and they continued the workflow throughout the pandemic. This paper came last year. It looked at the 1-year functional, cognitive, and psychological outcomes following the use of ECMO in coronavirus disease. came from the University of Michigan, a single center study. They evaluated the functional, cognitive, psychiatric, and post-traumatic stress disorder assessments in those patients. 23 patients, one more slide, or two more slides. 23 patients, 61% survived. And they concluded as functional impairment was common a year following the use of ECMO. Long-term anxiety, depression, post-traumatic stress disorders were also common, but cognitive impairment was not. This is the last paper I'll talk about, 2 slides. This was published in the Lancet last week. It was based on the ELSO registry, looking at patients with COVID-19 infection treated with ECMO, 4,812 patients in 349 sites in it can't be 421 countries. Have to go back and check that. They looked at 3 groups, 90-day mortality after ECMO initiation. So they looked at different periods of the pandemic. Before May 2020, that's group A1, the mortality was 37%. In the period between May to December 2020, mortality increased. So you think that with experience, mortality would reduce, mortality reached 50%. And for the ECMO, for the centers that started ECMO this year, the mortality reaches 60%. They attribute this to group differences, patient selection, the experience with ECMO in the center itself. So the late adopters were probably the centers who didn't have a lot of experience with ECMO. The early adopters were the centers who had good experience with ECMO, hence the difference in numbers. Patient selection, the patient treatment, were the patient intubated before, the length of the non-invasive ventilation, which is now stretched, that showed an impact on the rate mortality. Looking at the outcome of those patients, 25% of patients who received ECMO, it was an ECMO run for more than 5 weeks. So this is really labor intensive and heavy on the resource utilization. As I said, centers with less experience of ECMO had higher mortality rates, and sadly, less than 1/3 of those patients were discharged home. So look at those 3 graphs across the all group. So the blue here, those who are the patients who died. In the yellow, in the red, those are the patients who remain hospitalized. The white and the light blue, those are the patients who went to long-term care services. And only this amber yellow are the people who were discharged home. So despite all this and all these efforts, 25% of those patients went on. I think I'll no, sorry. We'll leave, yeah. So I'll be satisfied with this. I hope this was beneficial to all. Thank you very much for listening.
Thank you, Dr. Allah, for the explanation. You have enlightened us with a lot of practical points and studies with
It's been long, right? For the other types. Thank you very much.
Yes, yeah.
So I would like to introduce Ranganathan. She heads the Department of Cardiac Anesthesia at National Heart Center. His area of interest is in pediatric intensive care, cardiac intensive care, and cardiac surgery and anesthesia. We'll be speaking on best practices in cardiac anesthesia during COVID-19 pandemic. He actually has worked a lot of time in COVID ICU during this pandemic period. He has a lot of experience on this intensive care of COVID-19. Dr. Ranganathan.
Okay. COVID fine. Hello, good morning to everyone. At the onset, I would like to thank everyone, especially the invitees who had come on behalf of, at the request of our department, to come and spend a few hours and share their experience of COVID in various aspects. And I would like to especially thank Dr. Madan for taking his precious time and organizing this, and he's put in a lot of effort. Thank you, sir. And the administration as well. Before I start my talk, I want to confess 3 points. Even though 50% of our staff
and resources are utilized in cardiac cath labs. I have been very short on presenting some facts on COVID and cardiac anesthesia and cath lab, and I never thought of Kenny will be here for that. So apologies for that. My whole effort has been in concentrating on our role in OTs. Number two is I would like to thank all the other speakers who put in a lot of effort to present and very lucidly and elucidate their parts, which has made my job easier for the day. Number three is, again, there will be a lot of repeating themes because it's all the same in different ways, and we are going to look at the same problems in different ways. So probably a lot of repetition will be there. With these few words, I'll try to jump into the topic proper. So I have no disclosures. How we are going to divide the talk is looking at the pandemic and its consequence, disease pathology, and what we look for in preoperatively, drugs and its side effects in COVID and anesthesia, CPB and COVID, congenital disease, GUCH and COVID, and take-home messages. I'll try to keep it as short as possible. I'll try to skip as much as possible because I think most of the themes have been repeated again and again. Coming to pandemic and its consequence, this has been again put up by Dr. Ala previously. The whole problem when COVID started was the sharing of resources, and it has been a main area of contention between non-COVID care and COVID care. And when the pandemic hit us, there are a lot of areas which the COVID care and non-COVID care have in common, and we had to share all these resources. So the pull and push of various departments did play a part, and I'm sure it did play a part in NHC. So, but having said that, we have come out well, and we have by and large maintained a good resources allocation for essential services. This is a landmark paper which came in the Society of Thoracic Surgeons analysis by Nguyen et al., which showed a 53% reduction nationwide in all cardiac surgeries during the COVID era, with a 65% elective cases being cancelled and 40% reduction in emergencies even. The next chart shows an idea of how to clear the backlogs that have been developed in various centers. By God's grace, we don't have much of a backlog since we have been able to operate almost daily, and we could carry on with our services. So this gives an idea on what capacity we need to work to clear the backlogs and when we should start operating at full capacity. Coming to risk factors, has been elucidated by Dr. Khalid in previous slides. Any run-of-the-mill case which comes to you for cardiac surgery or ACS has something common with COVID. We share the same risk factors: diabetes, stroke, bronchial asthma, hypertension, smoking, cerebrovascular accidents. So many things are common between COVID and cardiac cases. So we need to understand the impact of that. Most of the COVID deaths are due to cardiovascular deaths, cardiovascular side effects, which Dr. Khalid has already elucidated clearly. So we need to know that cardiac cases with COVID have higher mortality and higher incidence. Coming to sequelae of COVID. Mechanism of action of COVID is through AC receptors. We all know that. And this is what Dr. Khalid was trying to tell initially. The basic mechanism of action of COVID is by producing a cocktail of inflammatory mediators, which include interleukins, TNF alpha and beta, interferons, and all the other cocktail antibodies. Everything together makes a soup of that and goes and attacks the lungs and the heart. So in the lungs, it can produce pneumonia and ARDS, and it directly can affect the heart and cause myocardial injury, arrhythmia, thromboembolism, and endothelial injuries. The endothelial injury in turn can lead to acute coronary syndromes, heart failure, cardiogenic shock, and pericardial effusion and tamponade. This is what Dr. Khalid was telling earlier. What are the mechanisms of ACS in COVID? It can be of various reasons due to systemic inflammation, hypoxia, demand-supply mismatch, vasospasm, plaque rupture, and coronary spasm. Coming to cardiovascular side effects of COVID, myocarditis, hypoxia-induced myocardial damage are the main reasons why troponins are seen raised. We can have something called the stunned myocardium, which we need to be aware because it can produce cardiogenic shock post-operatively, intraoperatively, and even preoperatively in the COVID ICU. RV dysfunction is for a given the fact that there is a high afterload for RV due to high ventilatory requirements and mean airway pressures, and the high incidence of pulmonary thromboembolisms. All these things can cause RV dysfunction. It can directly cause cardiomyopathy and LV dysfunction as well. Arrhythmias are very common in COVID, atrial and ventricular both, and acute MI, as has been said, are also common due to various reasons said before. How do we go about it? We need to have a good monitoring intraoperatively to know the state of heart during the procedure intraoperatively. We can rely on PA catheters, TOE. TOE helps a lot in assessment of fluid for the patients and optimizing fluid treatment and the choice of inotropes, whether we need pressors, inoconstrictors, inodilators, or what inotropes you essentially need to choose. It can be helped, TOE can go a great length in helping you to assess the patient status. Indirect monitors, invasive monitors like float track and PICO also has a role in assessing these patients. The respiratory effects are well known. I'm not going to the details of it, but more important to keep in mind when you take up a patient in the OT is the high incidence of pneumothorax. Acute increases in airway pressures, you need to keep this in mind. Lung ultrasounds go a long way in helping you intraoperatively to diagnose pneumothorax just after maybe intubation or connecting the patient to the ventilators. And it also helps you in assessing the lung severity, assessment of lung severity, because many of the patients may not come with a CT done. So indirectly, we can know the disease severity and involvement of lung by doing lung ultrasound. Coming to COVID and renal issues, most of the patients with COVID, they do come with AKI, as has been said, which in turn can have fluid and electrolyte imbalances. Proteinuria and hematuria are also commonly associated with COVID. So these things need to be kept in mind when you take up patients with COVID for cardiac cases. CRRT has to be instituted when indicated, especially for clearing excess fluid and picking up patients with very high renal function values. So CRRT is a good tool to have. And more importantly, goal-directed fluid therapy is known to help the patients in those who have cardiac dysfunction and renal dysfunction. So both ways, it's very important to know all this. Coming to hematological issues, the patients with COVID are known to have a lot of coagulation disorders. I feel that COVID, as much as it can be a respiratory disorder, it is a coagulation abnormality as well, because they do have multiple coagulation disorders like prolonged TT, APTT, and increased INRs, along with abnormal platelets. So we need to be aware about the coagulation status of the patient intraoperatively and perioperatively. Antifibrinolytics do have a role, and it has to be used judiciously to avoid multiple transfusions, because TRALI is very bad for COVID patients. TRALI can cause post-operatively respiratory dysfunction. And so use of platelet-rich plasma and coagulation factor concentrates are recommended as against whole blood and blood products. So you have to keep in mind incidence of TRALI when you're taking up patients for cardiac surgery because of their susceptibility to inflammatory mediators. COVID and GI side effects include diarrhea and vomiting, and they can suffer from electrolyte abnormalities and GI bleed as well. When it comes to endocrine, most of the patients with COVID do have hyperglycemia and hyperosmolar non-ketotic coma. So they may need fluid resuscitation and electrolyte correction before you take up, and institution of insulin infusions to correct the glucose values before you take up, because as already Ada has mentioned in that paper, and IRAS, they particularly mentioned correction of hyperglycemia as one of the goals for early recovery, and decreasing the incidence of post-op infections as well. Coming to CNS side effects, encephalopathy and meningitis can be some of the presentations of COVID, which need to be ruled out before we take up. And it need to be ruled out by doing lumbar puncture in case you have any doubts about the CNS viability. We need to monitor CNS with the use of cerebral oximetry probes, because we are going to do cases under CPB, and the risk of stroke is higher than normal than in the normal cases when you take a COVID case. So cerebral oximetry and cerebral monitoring is of essence in patients who have been taken up for COVID. Coming to CPB, as has been said earlier, COVID is a disease which is known for creating cytokine storm and exaggerated inflammatory response. And add to that, when you take a patient for cardiac surgery on cardiopulmonary bypass, the reasons can be multifactorial, as can be seen, including anesthesia, CPB, surgical trauma, myocardial ischemia, and cardioplegia. All in itself can cause inflammatory response. So they have come up with something called the 2-hit model of CPB plus COVID. Adding COVID plus CPB in these patients can create a cytokine storm with exacerbated systemic inflammatory response, resulting in pump lung, ARDS, and post-op respiratory failure. I would go even further, saying a 3-hit model of CPB, because add to that the incidence of blood and blood transfusion requirements post-operatively. So it's a huge inflammatory mediator soup that you feed the patient, and you can land up with severe respiratory complications post-operatively. How do you attenuate SIRS on CPB? For that, you have to think of other alternatives, including off-pump surgeries when feasible, trying not to cool the patient much, doing the cases normothermia, or if required in mild hypothermia, shorter CPB runs as is mandatory for all cases. Heparin-coated circuits decrease the inflammatory response during CPB. Ultrafiltration do play a key role in taking off the inflammatory mediators during CPB runs, and it helps in maintaining the fluid balance of the patient as well. Steroids definitely has a key role post-operatively and perioperatively to decrease the incidence of cytokine storm. We need a high dose of steroids as recommended for good outcomes post-operatively. Complement inhibitors is also recommended for decreasing the cytokine storm. So what are the challenges in CPB? Heparinization itself is a challenge in CPB because of a higher requirement of heparin dose due to antithrombin 3 deficiency in COVID-3 patients. And incidence of DIC and suspected DIC is very high. So you need higher doses of heparinization, more frequent monitoring of ACT perioperatively. Avoiding antifibrinolytic is very much required in confirmed or suspected COVID patients who have DIC. Ultrafiltration, as I said, is very important part of CPB to keep a fluid balance, because many patients come with fluid overload because they may be loaded with fluid for treatment of shock preoperatively. Gas scavenging from CPB is very important because it can expose the personnel around to COVID virus. So the effluent gas from the oxygenator need to be scavenged out. Higher FiO2s and sweep rate for CPB need to be instituted. So coming to the post-operative course, it has been shown that you can use TNF alpha in blockers like adalimumab for better post-op outcome to decrease the systemic inflammatory response. So coming to perioperative testing. When we come to perioperative testing, there are two things that comes to mind: whether the patient is actually positive or actually negative. So that depends on how you're going to interpret the results of RT-PCR. I am sure Dr. Amal will agree with me. It depends on the prevalence in the community. In a place where there is high prevalence, a negative predictive value of RT-PCR is low, whereas in a place with low prevalence, the positive predictive value of this test is going to be low. And if you want further elucidation of the patient in which COVID spectrum he or she is, you can always add on an IgM and IgG antigen testing so that it will give a clear idea as to where this patient is actually. Coming to triaging of patients and perioperative SARS-CoV testing, Tier 3 patients are those which are emergent cases where you go in without even testing the patient and you take full PPE precautions and assume the patient is COVID positive and go ahead and do the surgery. For those which are in Tier 2 and Tier 1, those are the intermediate and lower acuity cases, you need to consider the probability of testing based on exposure and probability of the patient harboring COVID infection. Accordingly, you do the test and go ahead and proceed with the cases. How about triaging and outcomes? When you think of triaging, there are 4 things that you take into consideration. One is the benefit from the procedure. Is it of survival benefit or is it for symptomatic benefit? And how does it benefit the individual, whether it benefits hugely or it's just a futile exercise? And the third thing is the timing for the procedure. Is it of emergent nature or it's an elective case as such? And the availability of resources. These are the 4 important things that you keep in mind in any pandemic, leave alone COVID. And this is triaging depending on the availability of bed. Resource allocation and bed allocation in pandemics is very important. So if we have, say, a 20% allocation of bed for non-COVID cases or non-pandemic, non-COVID cases, you need to do only emergency cases. When the resource bed allocation is about 40%, then you can take in those patients who cannot be discharged without surgical interventions. These are the patients who are in Tier 3. And Tier 2 patients are those who are awaiting surgery, who have LV dysfunction and CAD. And these patients can be done if the bed allocations is up to 70%. So this is something we can look forward to as administrators. This is a cardiac surgery outcome in 9 UK centers whom they had taken up and done cases despite the fact that those patients were COVID-19 positive. They had come up with something interesting. They showed a mortality of about 24.5% as against a normal of 3.5%. So the mortality for COVID patients undergoing cardiac surgery is definitely high. They also showed they have a higher mortality rate when there is a respiratory involvement post-operatively, and the mortality for those patients is very high, about 37%. Again, impact of COVID on coronary artery bypass graft and its outcomes in the United States in the last year during the pandemic, which showed this is a good paper actually. I would request everyone who is in cardiac surgery to go through it. It throws in a lot of numbers actually. They showed a 36% reduction in CABG volume, and after a propensity score matching, it shows similar clinical outcome, even though there was a pandemic going on. So I don't think we should be scared of saying that there is a pandemic and we need to cancel all the cases, because outcomes, be it in terms of mortality, stroke, AKI, ARDS, or mechanical ventilation, has almost been comparable to the years previously. So I think we should not stop operating. Examining the impact of COVID-19 on cardiac surgery services. This is a good study by COVID Surgery Collaborative, wherein they studied 1,128 patients who are confirmed COVID cases who underwent various cardiac surgical procedures. They looked at mortality risk, which were male sex, age more than 70, and poor preoperative physical status. Again, they came up with a mortality rate of 30-day mortality rate of around same 24-25% in COVID positive cases. And 51% patients postoperatively did have severe respiratory complications, of which those patients who had severe respiratory complications, their mortality was again somewhere around 38%. So about around 50%, you can say. Early respiratory outcomes following cardiac surgery in patients with COVID-19. It's a good paper coming from Tehran, actually, wherein they showed that about a prolonged ICU stay in patients who have been COVID positive, 16% overall mortality in COVID positive patients, and the readmission rate to the ICU of 16%. And in those patients who are readmitted with severe respiratory complications, the mortality rate in their study was very high at 75%. This is another study which showed they studied just about 15 cases in single center retrospectively of patients who had COVID and who underwent cardiac surgery. Of that, 9 patients had normal recovery, 3 of them died. So the outcome of cardiac surgical patients who contracted severe COVID-19 infection perioperatively is extremely poor. They suggested the use of early intubation at the earliest sign of post-op respiratory complication and use of high-dose corticosteroid for better outcome. What about COVID and congenital and GUCH? This is another part of cardiac surgery that has not been talked about. So sorting and triaging of patients with congenital heart disease can be done in 3 ways. Emergent cases, this is for neonates, semi-elective and elective. Emergent cases includes duct-dependent cases, TGAs, obstructive PAPVR, and severe hypoxic cyanotic congenital heart diseases. And elective cases are those non-obstructive PAPVRs, large VSD with failure, truncus, AP windows, and so on and so forth. And they are also given for children who are not neonates. They are divided into emergent, urgent, and elective cases. So this is how we can triage patients coming with congenital heart disease. As Dr. Alla had talked about, how do you consent patients in congenital heart disease with COVID? So essentially, how we are going to talk to the parents is the risk of no treatment versus the procedure, whether to go ahead with the procedure or to risk no treatment and let the COVID run its course. And what is the likelihood of outcome when you do intervene and at which point of time? And to find whether there is an alternate therapeutic approach which can be done without going on pump or doing cardiac surgery like in cath lab. Do keep in mind the high incidence of heart failure, arrhythmia, and stroke in kids who are COVID positive. So what about the clinical outcomes of COVID-19 patients with adult congenital heart disease? So this paper looked into it and they came up with risk factors of comorbidities of 2 or more, overweight patients, and cyanotic heart disease. You can see the odds ratio are very high and the p-value is very low for all that here. So these are the 3 risk factors that are more important in adult congenital heart disease, apart from the fact that unrepaired cyanotic heart disease and Eisenmangers did have a very high mortality in which. This is an Indian study which compared COVID positive outcome in children with heart disease, operated and non-operated. They looked into about 9,000 cases, of which about 90 patients were COVID positive. And the study found the pre-procedural mortality rate itself was very high at about 40%. So coming to the next important area of contention for during COVID is resource allocation, especially PPE. PPE is a valuable resource during COVID, and the use of it was restricted multiple times in our own centers. So these are the 3 levels of PPE use, as can be seen. So there are various ways of looking at and rationale for use of PPE equipments, what to use, for whom, and where. Essentially, level 3 PPE is required for intubating anesthetist and for people around the vicinity of any aerosol generating procedures and intensivists and nursing staff who are handling COVID positive patients post-operatively. The European guidelines have a funny way of looking at it. They just look at the PCR test. They consider 3 things. One is PCR test, symptoms, and direct contact. If any one of the following is positive or suspected, they go in for full PPE. I think a more nuanced approach is more appropriate in our settings. So what about the conduct of anesthesia? Coming to induction and intubation. So what do you, as a cardiac anesthetist, is required to know, and what is it that people expect from you? So most importantly, handling of safe airway management is very important. And it's your role for performing crisis management simulation in the OT so that the staff along with you are well prepared to deal with such scenarios as and when it happens. And you should have a good idea about decontamination of theater and contact areas. So these are the 3 things I would say that you are expected to know as a cardiac anesthetist. And this aerosol generating procedures, you should people who are working in the environment should have a fair idea of what all constitutes an AGP. So all these things constitute an AGP, and we should be well aware about how to protect yourself from AGPs. And this is an interesting slide which I want to show because there has been a lot of controversy about high flow nasal oxygen therapy patients being received in OT who are COVID positive, and the fear that it may spread COVID-19. Yeah. So, but the thing is, as you can see, there are a lot of studies which are differing in their outcomes. So I don't think it needs any more. I think it's better to avoid people on HFNO and take full protective equipment for dealing with such situations. Airway management, the most important thing is safe, accurate, and swift management of airway is most important in COVID-19. It's better to create COVID-19 kit dumps so that all these instruments, if not used, can be thrown off once the case is over, so that it can be disposed of and not be reused. And this is the slide showing the difficult airway management for patients who are COVID positive. Most important to note is avoidance of awake intubation. General precautions in the OT, a negative pressure anteroom for cold area and OT is required. If you are using a positive pressure room, you need to keep the positive pressure at a low settings. And you need to cover all machines with transparent plastics as we have done on our OTs. So these are things that need to be done. And one more thing, no one should enter the room once the procedure is over for 30 minutes for the AGPs to clear off the atmosphere. So as has been said, intubation is the most important thing, and we need to use video laryngoscope to intubate these patients, and you need to clamp the line, connect the suction catheters, HME filters before releasing the patient's clamp to the ventilator. So this needs to be done to decrease the incidence of AGP after intubation. Intra, you need to use lung protective ventilation strategies and minimize gas flows to avoid contamination of air, and you need to scavenge the expiratory gas port as much as possible. And they have recommended selective use of PE. American Society of Echocardiography has considered PE as a AGP, and so they have recommended use of a full PPE for for personnel using PE. So these are few sites to show the drug interactions of various drugs that has been used in COVID, which can be of concern for you in the OT. I'm going to run through this because of lack of time. Extubation in patients who are COVID positive, as much as positive, it's best to electively ventilate and rather than contaminate the pathway and the people around. So it's best to electively ventilate post-operatively and extubate the patients in dedicated ICUs. It's of value to give dexmedetomidine, antitussives, and opioids to decrease the amount of coughing and decrease aerosolization. Post-procedure standard transferal should be done with the use of portable ventilators because, again, it decreases the contamination of areas around and protects the personnel. So post-operatively, you need to look out for myocarditis and pericarditis, cardiogenic shock, vasoplegic shock, acute coronary events, thromboembolism, RV dysfunction. All these things are very common post-operatively once you have operated them on CT. So the take-home message is cardiac anesthesia is an integral part of the multidisciplinary team for triaging and care of cardiac cases. So we need to be aware about the implications of COVID. Awareness about treatments in COVID and complications of COVID is essential for doing justice to the patients you have taken in. You have a definite role in sterility of OT and flow management of the OT. Safety of co-workers is your responsibility as well. So you need to be ready to teach the co-workers about how to protect oneself from AGPs especially. Management of inotropes and pressors for complicated cases is very important, and you have to have a sound knowledge about it. Thank you.
I would like to request all the speakers to come forward and we go for a question and answer session. Yeah. Our floor is open for discussion.
Stop question, anyone? Question, comment?
And it's just one for the-
You can talk.
One question.
One question about your specialty. When you say the CT, the side, now the originally they said about 35 below is infectious and about 35 is non-infectious. Now has that limit changed? Okay. This one. This one.
Thank you for the question. Actually, there is no limit. There is no limit like 35 or so. It has to be correlated with the patient symptoms, clinical presentation. But this was put like based on many observational studies. So there is no like isolation like 35 or so. But 35 is usually associated with the prolonged chilling, and most likely the patient, if he has clinically improved, then this is the non-infectious patient in most of their times, especially as severe form.
This question is for what is our experience here with COVID-19 and
So thank you for the question, first half. ECMO was a hot subject when it came and when it was discussed for COVID-19 patients. As you know, we have good experience with ECMO, but the application for non-close cardiotomy ECMO hasn't been that widely practiced. We have good successful BB ECMOs and we have good VA ECMOs post cardiotomy. When we looked at our resources, when we came to discuss the ECMO for COVID, it was clear to us that we don't have enough resources to cover those patients. That was when we did the math, we did the numbers, it was sadly the fact. And even if we had asked for more resources, which was offered to us, these resources would be better utilized in managing COVID-19 patients or managing the cardiac surgery patients who are on the wait list. That's why, after many discussions, we decided that we will not go ahead with this. Added to that, the mortality, as you said, the survival to discharge, the knowledge about ECMO. So these papers that I presented only came last 2 months. In the middle of the pandemic, no one knew what ECMO would really do to those patients. Had high mortality rates. The decision here was against ECMO for COVID-19.
my second question maybe before somebody. So like the technical things you mentioned in the presentation about the importance of negative pressure chamber for operating room when we do surgeries for COVID-19 patients. In our hospital here, we have induction room, which usually we don't use if it serves patients sometimes. And can we isolate that induction room from the OT and keep induction room, for example, a negative pressure chamber in this building, or it's not possible?
I think the requirement, the engineering and requirement for a negative pressure room is completely different. I don't think you can make our positive pressure room that is at present, the both OT and the induction room into a negative pressure room. It's not possible like that. It's something a dedicated, different idea of how to build the whole thing actually. So it's basically completely different thing. You cannot make one into the other without completely dismantling whole stuff. So they recommend 12 to 20 air cycle change for a negative pressure room to be effective. It's not just any negative pressure room. You need to have these numbers in place if you have to keep the area very sterile. So it's important that they say that the patients be done in negative pressure room itself, and OT should be negative pressure room. But positive pressure room OT is a compromise. That's what, according to the studies, they say.
Actually, you cannot isolate. That thing is
Yeah.
very difficult, construction wise. Either you put the induction and operating on the same positive pressure or same negative pressure. But you cannot isolate the two at one.
I asked because this is a new building and the new hospitals actually they can isolate.
I think with the onset of this pandemic, people would be thinking about building negative pressure OTs as well for such cases.
Actually, regarding the ECMO, actually, I asked one of my colleagues in the Gulf states. And I told them these numbers of mortality which we have the lowest in the Gulf states. Are you taking the numbers or is it true?
Are they taking the numbers or is it true? They told me, currently I have 15 patients on ECMO, COVID. So it makes really a difference. When you have high level of care for sick patients with COVID, it makes really a difference. But you know, it's a heavy burden on the healthcare system. We have one patient on ECMO. We use 24 hours plus the residents plus the cardiologist plus it's all the resources should be devoted for the ECMO cases. But you know, we have a lot of that because of this very high level.
But the other way of looking at it of ECMO patients is it's just a learning curve actually. Once we have 15 patients in one room, I'm sure Salah will be able to manage all of them at one go. You don't need multiple practitioners.
I go back to resource utilization. It's all about resource utilization. I asked my colleagues in Vancouver General Hospital, they had 30 patients on ECMO at a given time during the pandemic. Their survival was around 40–50%. So that's again, arguably a high level of care. But I asked the perfusionists in Seattle, their team, again, Seattle is a known center, their team was against ECMO for COVID, simply because during COVID pandemic, they developed experience with high frequency ventilation. So when choice comes between putting the patient on ECMO or high frequency ventilation, they will go with high frequency ventilation. And they claim the results to be similar to ECMO outcomes. Again, this is how you look at it.
I have one question. You know, the immunity we have so negative, we have the antibody. You know, I come across some patients who are on this connective tissue disease patients who are on immunosuppressive therapy. And they got the vaccine and using the antibodies and nothing. So, is it purely cell-mediated? Is it purely antibody-mediated? Which one you rely on?
Actually, I have seen some patients, like especially those like anxious, concerned patients on immunosuppressant, they will go and it's usually done in private, they will pay to take their antibodies level. I don't think it's very helpful for their own health, checking the antibodies. I'm really against that because it increases the anxiety. We believe that most of the vaccines, whether vector-based or mRNA vaccines, they work on cell-mediated and memory cells. So it's not like correlating with the immunogenicity, how much antibody in the liver is the immune level. So if they find like 200, they are scared and anxious, and then it's only 200, I have not reached thousands, and they come up in the clinics and they think about boosters, and they go also, even like nowadays, the guidelines, national guidelines are not advising for boosters yet, but they go and take boosters, and I have a few patients like that. So I would say that we could assume that memory cells are there, T cells, and they have some immunogenicity against the virus, and it does not correlate well with the antibody level.
You know, like the hep vaccine, we rely on the antibodies. I mean, those who didn't take the booster dose of hep vaccine, the pre-vaccine, we give them booster dose, or we suggest booster dose for them. because we are monitoring the antibody. So it means that with COVID, it's more of cell-mediated rather than antibody.
Exactly. And the COVID-19 like vaccines are different from the Hep B vaccine, so we don't expect the same response.
My question is to Dr. Khalid. What do you think? What is the explanation of this myocarditis or myocardial or insult? Is it because of high inflammatory systemic inflammatory burden, or what do you think? What are the other explanation for this myocardial insult?
I mean, as we said, it's like multifactorial. Now, is it myocarditis? We don't know for sure. We know there are some reported cases like infiltrate, but the evidence is not conclusive. So I think the best case report we had is in a patient with picture of myocarditis and evidence of infiltrate on endomyocardial biopsy, and they have seen the virus in the tissue, but the virus was residing in a macrophage, not cardiomyocyte. That really doesn't confirm, because macrophages could be coming from the circulation. So we are not sure about how much of this just pure direct myocarditis, direct myocardial invasion. So actually, when the pandemic hit the United States, there are a lot of people who started scanning those patients with MRIs. And with that, they have seen NHC enhancement maybe less than what they were expecting, less than what they would expect with myocarditis. So they have patients with very high troponin level. Clinically, they are suspecting myocarditis. They see nothing by direct MRI. So that tells you like you have a lot of other mechanisms, not just necessarily it's myocarditis, but you have all those other possibilities that can lead to microvascular dysfunction, endotheliitis, microangiopathy, thrombotic microangiopathy, microthrombosis. All those hypotheses are there. Then you have the damage directly exerted by the cytokine. So when you have a cytokine storm, then those cytokines, and actually other inflammatory markers like I think Dr. Ramay mentioned them, like alpha and even the H of protein, all those can exert direct damage into the myocardium. And of course, we should not forget the hypoxic injury and the demand ischemia, which is common. Those patients are in the ICU on ventilator, they are hypoxic. So that's also contributing. And then, of course, the stress cardiomyopathy is well known in those patients with critical illness. Actually, if you look at the causes of myocarditis, if you look into the list, if you see any guidelines, like for example, say you look at the latest fourth universal definition of myocardial function, and then you will find a table with a list of all the reasons for acute myocardial injury. You go through them, and you find that most of those things can be found in COVID-19 patients. One of them is very simple, it's critical illness. You will find that critical illness is one of the causes of acute myocardial injury. And who will have more critical illness than a COVID patient admitted in the ICU? So I think it's multifactorial. I think trying to say this is on myocarditis or this is just microthrombosis. If you try to say this is one thing, I think you are likely to be wrong than if you say this is multifactorial. Probably more than one factor contributing to the troponin elevation.
If you see troponin level is high, you see myocardial dysfunction. There's some postmortem studies on COVID patients. They found the viral genome and the cardiac myocyte. The virus itself has very avid for angiotensin II receptors. And people even raise that issue. You have something with LV dysfunction, although it's a hereditary issue. LV dysfunction, we promptly start them on ACE. And even with the ACE inhibitor, those patients they express more of these receptors on the cardiac myocyte. So there is some sort of theoretical concern that hasn't been substantiated by any clinical trials. So there was one post-mortem study found really the viral genome on the cardiac mice. And as you said, yeah, it's multifactorial, yes, but we know most of the cases of dilated cardiomyopathy worldwide now, we see somebody with LV dysfunction suddenly coming for screening, you find here 20%. Most of them they had myocarditis, Coxsackie virus, and it's cool. Recover from the but that was the sequel of the viral myocarditis, and this is the most common cause of LV dysfunction, not related to the coronary, not related to the problem.
Can I ask you? Dr. Khalid, that was a very nice lecture. Now, when you keep saying troponin, what type of troponin do you mean? Is it troponin P or troponin I? Second thing is, we all know that COVID induces thrombodensity, hypercoagulable state. So, in your clinical practice, if you have to accelerate the dose of antiplatelet drug, like a lot of patients relatively take aspirin and the other drug, even though they are healthy. Did you have to increase this anticoagulation measures either after PCR or in normal people?
No, actually, there is no guidelines as such to suggest that COVID patients should be treated differently than the other general population. And usually, COVID infection would be transient, and those patients would go on and eventually become like anyone else. We know that maybe there is more microthrombosis. Actually, one of the slides I showed you that was a STEMI registered from Spain. It clearly showed that stent thrombosis is more common in patients with COVID versus non-COVID. But there is really no guidelines to suggest that maybe you need to treat this more aggressively first. What are you going to do? Maybe theoretically, I would say, if you have the option between, let's say, Adlaris in terms of history or dual antibiotic therapy, if you have the option of Adlaris versus some other stronger antibiotic therapy like Tagliol or Prasugrel, I would probably in those patients maybe select something stronger like Tagliol or Prasugrel in addition to aspirin instead of that. Maybe that's the only thing I would say, but otherwise there is nothing specific that you can do about it other than just you do the usual care.
Actually, the definition is the same. Definition of myocardial is when we set according to the lab above 99%, just above the noise level. This is say whether it is T or whether it is I. From many benefits, they said many benefits are given you the kit for the Troponin. Troponin T is worldwide unified for post diagnosis. So more of standardized for the other the Troponin I is not. One last comment or question before we go for a break. It was a break, stream now to 10 minutes.
My question is for Dr. Khan. Firstly, it's an excellent presentation. And what I would like to know is the myocardial damage permanent in the COVID survivors or is it recovered? Like you are following up the COVID survivors in COVID.
Yeah.
Has the myocardial damage has recovered or it's persisting?
So this is clear. So we don't know for sure. Now people are talking about long COVID. And a lot of this long COVID, yes, they are, especially when it comes to the media. In this media, we are talking about symptoms of COVID. Patients who get COVID and after COVID for weeks and weeks, they have fatigue and so many other symptoms. But there is also something else. There is a real pathology that we are not sure whether it's going to improve. What is the clinical impact of this? We don't know. But we have studies of cardiac MRI studies in months after COVID, and they still have the NG enhancement and so on. What is the clinical significance of that? Now I don't know. So we will know just like later on, but for now there is no clear evidence that maybe like what are the long-term sequelae of this, we don't know. Of course, if a patient who already got LV dysfunction, in my expectation as Dr. Hamid said, it's the same as any patient with viral myocarditis, which we were dealing with all along. Patient with dialytic myopathy, a significant proportion of them we know from viral myocarditis, some of them endemic. So, the natural history, I think, would be similar to anyone else. Now, what about a patient who is asymptomatic, completely asymptomatic, had a COVID infection a year ago and went well, and now you do cardiac MRI and you see NG enhancement? What is the clinical significance of that? I don't know. I don't think there is anybody who got the answer to that. Maybe in the future we'll realize that those patients with NG enhancement are more likely to go on to the clinical symptoms like cardiomyopathy and so on. But that's time only.
Would like to thank all the speakers for the excellent presentation. 10 minutes break. We'll go for a 10-minute break and we'll assemble back here.
This is one. It's like.
Sorry.
ஆப்கானிஸ்தானின் குந்தூஸ் மாகாணத்தில் உள்ள மசூதியில் நடத்தப்பட்ட தாக்குதலில் 100க்கும் மேற்பட்டோர் பலியான சம்பவத்திற்கு ஐக்கிய நாடுகள் சபையின் பாதுகாப்பு கவுன்சில் கடும் கண்டனம் தெரிவித்துள்ளது. மிருகத்தனமான மற்றும் கோழைத்தனமான இந்த செயலை நிகழ்த்தியவர்கள் அதற்கு துணை போனவர்கள் என அனைவரும் சட்டப்படி தடுக்கப்பட வேண்டும் என தெரிவிக்கப்பட்டுள்ளது. நெட்ஃபிளிக்ஸ் ஓடிடி தளத்தில் தொடராக வெளியாகி வரும் பெரும் வரவேற்பை பெற்ற பீக்கி பிளைண்டர்ஸ் 2023ஆம் ஆண்டு திரைப்படமாக வெளியாகும் என அறிவிக்கப்பட்டுள்ளது. இதுவரை 5 பாகங்களாக வெளியாக உள்ள இந்த தொடரின் இறுதி பாகம் அடுத்த ஆண்டு வெளியாக உள்ளது. இதனைத் தொடர்ந்து திரைப்படமாக வெளியிடப்பட உள்ளதாக தயாரிப்பு நிறுவனம் அறிவித்துள்ளது. T20 உலகக்கோப்பையில் இந்திய அணியை தொடர்ந்து ஆட்டக்காரராக விளையாட தேர்வுபெற விராட் கோலி கூறியதாக மும்பை இந்தியன்ஸ் அணி ஹைதராபாத் அணிக்கு எதிரான ஐபிஎல் போட்டியில் உலகக்கோப்பை கிரிக்கெட் தொடருக்கான பாகிஸ்தான் அணியில் 3 முக்கிய ஹைதர் அலி உள்ளிட்ட வீரர்கள் அணிக்கு திரும்பும் நிலையில் இடைக்கால தலைமை பயிற்சியாளராக அந்த அணியின் முன்னாள் வீரர் சத்யன் முசா நியமிக்கப்பட்டுள்ளார். செவ்வாய் கிரகத்தில் உயிரோட்டம் இருப்பதற்கான சாத்தியக்கூறுகள் உள்ளதாக நாசா விஞ்ஞானிகள் விளக்குகின்றனர். செவ்வாய் கிரகத்தில் ஆராய்ச்சி மேற்கொள்வதற்காக அமெரிக்காவின் நாசா நிறுவனம் கடந்த ஆண்டில் பெர்சீவரன்ஸ் விண்கலத்தை அனுப்பியது. விண்கலத்தின் ரோவர் செவ்வாய் கிரகத்தில் உள்ள எபேரோஸ் பள்ளத்தாக்கு பகுதியில் தரையிறக்கப்பட்டது. இந்த நிலையில் ரோவர் கருவி மூலம் எடுக்கப்பட்ட புகைப்படங்களை நாசா வெளியிட்டுள்ளது. இதில் செவ்வாய் கிரகத்தின் மேற்பரப்பில் அமைந்துள்ள மலைகள், பாறைகள், அடுக்குகள் ஆகியவற்றை இதுவரை இல்லாத அளவு துல்லியமாக காணப்படுகிறது. பெர்சீவரன்ஸ் விண்கலத்தின் செயல்பாடுகளை புளோரிடாவில் உள்ள நாசா வானியலாளர் ஏவி வில்லியம்ஸ் தலைமையிலான குழு ஆய்வு செய்து வருகிறது. புகைப்படத்தில் காணப்படும் அடுக்குகளின் வடிவம் சுமார் 3.7 பில்லியன் ஆண்டுகளுக்கு முன்பு செவ்வாய் கிரகத்தில் நீரோட்டம் இருந்ததற்கான ஆதாரமாக இருக்கலாம் என்றும் ஏவி வில்லியம்ஸ் தெரிவித்துள்ளார். செவ்வாய் கிரகம் குறித்த ஆராய்ச்சி மேற்கொள்வதற்காக 2013ஆம் ஆண்டிலேயே மங்கள்யான் விண்கலத்தை வெற்றிகரமாக இந்தியாவின் இஸ்ரோ நிறுவனம் அனுப்பியது குறிப்பிடத்தக்கது. இடைவெளியுடன் செய்தி தொடர்புகளை சிக்கல் நிமிஷம் தொடரும்.
Apa dia? நல்லா இனிப்பா இருக்குதா? ஹலோ அந்த இதை கொஞ்சம் வெட்டி அதை கொஞ்சம் அமைச்சுக்கோங்க. காலிஃப்ளவரா?
இந்தியாவிலே 1 லட்சம் சர்க்கரை மருத்துவர்கள் மிக பிரம்மாண்டமான ஆசிரியரும் அவகாசமாக மாணவர்களும் சாதிக்கலாம்.
இல்லப்பா
Antibodies India's #1 goal by yes. வழங்கும் பேசும் தலைமை.
புக்கு தான் நிறைய இருக்கு.
Using the இதுவரை இல்லாத அளவுக்கு அதிகம் பேர் பயன்படுத்துவார்கள் என அமைச்சர் மாசுபடி தெரிவித்துள்ளார். கூறலாம். சென்னை பெருநகரங்களில் வசிக்கும் நரிப்பகுப்பு சமூக மக்களுக்கு கொரோனா தடுப்பூசி செலுத்தும் முகாம் நடைபெற்றது. இதில் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் சுப்பிரமணியன், துணை செயலாளர் ராதாகிருஷ்ணன், மாநகராட்சி ஆணையர் ககன்தீப் சிங் பேடி, பொது சுகாதாரத்துறை இயக்குநர் செல்வ விநாயகம், சென்னை மேற்கு மாவட்ட திமுக பொறுப்பாளர் சிற்றரசு உள்ளிட்டோர் பங்கேற்றனர். பின்னர் செய்தியாளர் பேசிய அமைச்சர் சுப்பிரமணியன், தமிழ்நாட்டில் முதல் தவணை தடுப்பூசியை 64% பேரும், இரண்டாவது தவணையை 22% பேரும் செலுத்திக் கொண்டுள்ளதாக தெரிவித்தார். தடுப்பூசி செலுத்தியோர் எண்ணிக்கையை 70% உயர்த்த நடவடிக்கை எடுக்கப்பட்டு வருவதாக கூறிய அவர், இரண்டாம் தவணை தடுப்பூசி செலுத்தாமல் உள்ளவர்கள் நாளை நடைபெறும் முகாமை பயன்படுத்திக் கொள்ள வேண்டும் என கேட்டுக் கொண்டார். நீட் தேர்வை தாக்கம் குறித்த ஓய்வு பெற்ற நீதியரசர் ஏகே ராஜ் குழு அளித்த அறிக்கை 7 மொழிகளில் மொழிபெயர்க்கப்பட்டுள்ளது. நீட் தேர்வில் இருந்து விலக்கு பெற சட்டம் இயற்றப்பட்டு ஆளுநருக்கு அனுப்பி வைக்கப்பட்டுள்ளது. ஆளுநரின் ஒப்புதலை தொடர்ந்து குடியரசுத் தலைவரின் ஒப்புதல் கிடைக்கப்பெற்ற பின் சட்டமாக அமலாகும் என கூறப்படுகிறது. இந்நிலையில் நீட் தேர்வை தாக்கம் குறித்த ஓய்வு பெற்ற நீதியரசர் ஏகே ராஜ் குழு அளித்த அறிக்கையானது தமிழ், ஹிந்தி, மலையாளம், தெலுங்கு, கன்னடம், பெங்காலி, மராத்தி ஆகிய மொழிகளில் மொழிபெயர்க்கப்பட்டுள்ளது. இது தொடர்பான அறிக்கையை சென்னை தலைமைச் செயலகத்தில் முதலமைச்சர் ஸ்டாலினிடம் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் சுப்பிரமணியன் வழங்கினார். மக்கள் நல்வாழ்வுத்துறை முதன்மை செயலாளர் டாக்டர் ராதாகிருஷ்ணன் உள்ளிட்டோர் அப்போது உடனிருந்தனர்.
COVID-19
மக்களுக்கு மறுக்கப்படுவதாக கூறிய விழுப்புரம் மாவட்டம் கண்ணமுக்கலம் ஊராட்சி ஒன்றிய அலுவலகத்தை முற்றுகையிட்ட அங்கன்வாடி ஊழியர்கள் நான்கு போராட்டத்தில் ஈடுபட்டனர். இது தொடர்பாக நமது செய்தியாளர் காமராஜ் நடத்திய கலந்துரையாடலை தற்போது பார்க்கலாம். தமிழகத்தில் இரண்டாம் கட்ட உள்ளாட்சி தேர்தல் சுமூகமாக நடைபெற்று எனக்கு வேணாம்னு சொன்னாலும் விடமாட்டாங்க. கண்டிப்பா போய் அவனுக்கு ஆர்டர் சொல்றாங்க. சரி, நாங்க மறுக்க முடியாம நாங்களும் ஆர்டர் வாங்கிட்டு எங்களுக்கு எங்க போறாங்கன்னா நீங்க சிரமத்தெல்லாம் பார்க்காம நாங்க போறோம், போயிட்டு கூட்டி பார்க்கிறோம். ஆனா எங்களுடைய ஓட்டு எங்களுக்கு உண்டா இல்லைங்களா? நாங்க வாக்களிக்கணும்ல, நாங்க வாக்களிக்கிறதுக்கு பாம்பு கொடுங்க, நாங்க வாக்கு போயிடலாம். 1ஆம் தேதியில இருந்து நாங்க வரோம். 1ஆம் தேதியில இருந்து எங்களுக்கு இந்த பீரியட் எந்த ரெஸ்பான்ஸ் கொடுக்கல. எங்களுக்கு ஒரு பொருட்டாவே மதிக்கல. அது கேட்கலாம். இப்ப சொல்றாங்க வானூர்ல நீங்க ஒர்க் பண்றீங்க, அதனால வானூர் போட்டதுனால உங்களுக்கு சவால் பண்ணி வரலன்னு சொல்றேன். அதே வானூர்ல தான் அவங்க டிபார்ட்மெண்ட்டை சேர்ந்த வேலை பார்க்கறாங்க. அவங்க எல்லாருக்கும் ஓட்டு போட்டுக்காங்க. எங்க அங்கன்வாடி பணியாளர் ஓட்டு மட்டும் போடல. அதுக்கு காரணம் என்ன? நாங்க 97ல நாங்க வேலைக்கு 97ல வேலைக்கு போறோம். 27 வருஷம் முடிஞ்சு 28வது வருஷம் நாங்க இதை வந்து நாங்க அங்கன்வாடி பணியாளர் எந்த டிபார்ட்மெண்ட் சொல்ற வேலையும் நாங்க செய்ய மாட்டோம்னு சொல்லல. எங்க வேலைக்குரிய சுமை எல்லாருமே கலெக்டர் போட்டு எல்லாருக்குமே எங்க வேலையில எவ்வளவு சிரமம் இருக்குன்றது அவருக்கும் தெரியும். சொன்ன காரணம் என்னன்னா இங்க வரல, உங்களுக்கு போட்டு வந்து லேட்டா வந்து இங்க வானூர்ல வேலை செஞ்சீங்க. அதாவது
வாயோட இருக்கு கஷ்டம் இருக்குது.
முக்கிய நீர் ஆதாரங்களை பாதுகாக்க தொடர்ந்து நடவடிக்கை மேற்கொள்ளப்படும் என்று அமைச்சர் மெய்யானது தெரிவித்திருக்கிறார். காற்றால் மாசுபடுவதை தடுக்க மேற்கொள்ளப்பட்டுள்ள நடவடிக்கைகள் குறித்து சுற்றுச்சூழல் துறை அமைச்சர் மெய்யானது அறிக்கை ஒன்றை வெளியிட்டிருக்கிறார். மேற்கு முதல் மயிலாடுதுறை வரை பல்வேறு இடங்களில் நீர் மாதிரிகள் சேகரிக்கப்பட்டு ஆய்வுக்கு அனுப்பப்பட்டுள்ளதாக அமைச்சர் மெய்யநாதன் தெரிவித்திருக்கிறார். காவிரி ஆறு மாசுபடுவதை தடுக்கும் பொருட்டு சென்னை ஐஐடி நிபுணர் குழு மற்றும் பல்வேறு வல்லுநர்களின் ஆலோசனைகளை கேட்டு தினமும் நடவடிக்கை எடுக்கப்பட்டிருப்பதாக அமைச்சர் மெய்யநாதன் தெரிவித்திருக்கிறார். அமைச்சரையாக பார்த்துக் கொண்டிருக்கிறோம். இது தொடர்பான கூடுதல் விவரங்களோடு சிறுதேவா இணைக்கப்பட்டிருக்கிறார். சிறுதேவா இது சார்ந்த செய்வாளர் விவரங்களை பதிவு செய்கிறார்.
So basically in this table, they divided the phases of the COVID time according to how bad these things are, like number of the patient in the ICUs or the limitation of the resources. Phase 1 is the easiest one. Phase 2, it's harder, but phase 3 is the worst time. So logically, we'll be canceling or delaying the surgery that are more elective later. So for example, I go to the phase 1. We will proceed with solid and predominantly solid, more than 50% lung cancer, and node positive lung cancer, nodal like hungry. Post-induction therapy cancer. And I think there's a slide. Maybe what have you done to my? Okay. It's okay. So this is the same one I just magnified. So this in phase 1, you can proceed with these cases. Post-induction therapy cancer, esophageal cancer, chest wall tumors of high malignant potential. And always you need to have an alternative treatment considered for those patients who can be deferred. So like you consider an endoscopic therapy, new adjuvant therapy, ablation, debulking, new surgical staging. So there will always be some kind of alternative treatment for those patients who are deferred, not only just deferred and forget about them. In phase 2, where the surgery is restricted to patients likely to have survivorship compromised if surgery not performed within the next few days. For those patients like perforated cancer of esophagus, tumor-associated infection, tumor-associated hemorrhage, management of surgical complication, hemothorax, empyema, infected mesh, and surgery to be deferred, all thoracic procedure typically scheduled as a routine. And at the same time, for those thoracic procedures typically scheduled routine, you have to consider alternative treatment. Phase 3, surgery restricted to patients likely to have their survivorship compromised if surgery not performed within the next few hours. And these include the perforated cancer of esophagus, threatened airway, tumors associated sepsis, management of surgical complication in unstable patient like active bleeding, not amenable to non-surgical management, airway or anastomach leak, and sepsis. Regarding the recommendation of management of the airway, also European Association of Cardiothoracic Anesthesiology, Thoracic Subspecialty Committee has developed a preliminary recommendation for airway management of thoracic surgical patients with suspected or confirmed COVID infection. These recommendations focus on the preparation of anesthesia, airway management, one lung ventilation, and extubation. So these are the recommendations, and I say like accurate patient screening. We need to screen the patient who should come to the hospital by telephone before they get hospitalized. Body temperature measurement of all patients before surgery. All patients should wear surgical face mask. Patients should wait in the Pre-operative holding area adjacent to the OR while maintaining social distancing. Patients should come alone unless they have an extinguishing circumstances requiring a family member to be present. Adequate PPE, double gloves, eye protection, fluid resistant gown, particulation respirator like N95. Apply HEPA filter between the mask and the breathing circuit. Avoid bag mask ventilation. If manual ventilation is necessary, small tidal volume, pre-oxygenation with 100% oxygen, 3 minutes of good pre-oxygenation, rapid sequence induction, which we usually use for emergency cases. Maybe this should be applied for all COVID patients instead of the normal induction. And Rocronio may be preferred over succinylcholine. Video laryngoscope to be used for all, disposable one if available. Orotracheal suction with DLT and immediate inflation of the tracheal and bronchial cuff. So we don't start ventilation before inflating the cuffs. So inflate the cuff, then start ventilation to minimize the air leak. Apply HEPA filter on DLT lumen. I show some pictures after that. Anyway, so I'll go through it while I'm going through the presentation as well. This table also is an interesting one because it compared the recommendation from different places of the world. So like United Kingdom, CRT in the Italy version, and Canada, Australia, China. So example for this, for the management, for airway management, team safety. Tracheal intubation is a high risk aerosol generating procedures. Everyone agree on that. Prefer elective tracheal intubation. Chinese don't agree with that. A recommendation for PPE. Chinese also don't agree with that. There's something interesting about the Chinese. Okay, I'll show you the next slide also. Then the hair cover, everyone will cover their hair. Hood, the Italian and Canadian, N95 and FFP2, almost everyone. Google eyewear, not the tail. Face shield, shoe cover, double gloving, almost everyone. Long sleeve, everyone. And HEPA filter, everyone. So basically, these are the things that we need to protect our safety from wearing this, and this is what we are practicing here in our NHC. Also the organization aspect and team communication. An isolated negative pressure room if available. Everyone agree on that. So if there is no isolated, if there's no negative pressure room, what do we do? It's the recommendation from everywhere. We don't intubate. We intubate. But I think if there is the AC switched on, we should switch it off to make it lessen the transmission risk. Limit staff present at tracheal intubation. Yeah. Maybe. I don't know why the Chinese they don't agree on this. So I think they allowed no certain number to go into the inside. Consider excluding staff vulnerable to infection. Only Australian. Effective communication. Everyone agrees except Chinese. Develop checklist. Yeah, you can. So basically, the thing that here, I mean, we need a negative pressure room. We need to limit the staff represented, and we need to consider excluding staff who are vulnerable to infection. And effective communication is paramount of everything. If there's a checklist to be developed, it's good. If not, it's all right. The other thing, intubation with SAS principles. SAS are safe. SAS is safe, accurate, and swift. So this procedure of intubating the airway should be safe for the team and should be accurate. I mean, that should be planned well before with the maybe best available experience, the best available equipment, and swift. So do it fast, finish it off, and proceed. Dedicated airway card should be available. Like yeah, most of the people believe in that. Pre-oxygenation with a 3 to 5 minute, all good. But pre-oxygenation is very important, especially if we're going to do an RSI, rapid sequence induction. So we cannot skip that. Tidal volume or full volume capacity. Avoid back mask ventilation if possible. Yeah. So that's what we start with. We avoid back mask ventilation. But if we fail to intubate, maybe we ventilate with a small tidal volume. Rapid sequence induction. Avoid cricoid pressure. Ensure full neuromuscular blockage. Yes, that's why we use urochronium, 1 milligram per kg. Video laryngoscope, it is a paramount. We should have a video laryngoscope available for every patient with COVID. Limit awake intubation. Why? Because we need aerolization, the patient will be breathing. So awake intubation only reserved for patients who have expected to have very difficult airway, and with those patients also you avoid aerolization. Avoid tubicalization. So this is the mnemonic I was talking about. This has, I mean, that procedure should be safe, for the staff and patient, accurate and swift. The operating room area separated into red, white, and yellow zone. The red zone is the operating room itself, and where two staff are donned with full PPE during the tracheal intubation, and that was before, should be performed by the senior anesthetist and assistants of a nurse. Yellow zone, the induction room attached to the operating room, and separated by a glass partition where an anesthetist is present with full don PPE in case he need the anesthetist in the red zone needs any help. And the white zone, an observer from the institutional infection control team present in the outside dedicated operating room where the surgery takes place, just to guide in the donning and offing and observe the quality of it. This is the ideal one, but I think in the practice it's very difficult because the limitation of the staffing, you cannot have just an anesthetist sitting in the yellow zone, and with the shortage has happened. I mean, these zones were really not very practiced, but that is the ideal thing. You already showed, I mean, Dr. Ranganathan have shown you this, but that this is specific for the thoracic. Tracheal intubation and lung separation for non-urgent surgery should be deferred until patient is non-infective. So if you can delay the surgery, you don't take the patient. A dedicated negative pressure COVID-19 theater if visible. Minimize the number of staff, most experienced anesthetist. Plan ahead, communicate effectively, PPE according to the level of hazard. Minimize airway manipulation. Use antiviral filter connected to the ETT or DLT. Closed suction system. Be prepared for treating hypoxemia during lung ventilation. Patients who are came for thoracic and they are going to subject it to lung ventilation, so they are prone for hypoxia. On top of that, they have COVID lungs, which is make it worse. Is lung separation actually or isolation is needed? So if the indication is soft, maybe you can go away with it. If yes, I mean, if no, just consider two lung ventilation. If no, you need to separate the lung. And if the patient intubated already, if the patient came from the ICU or from the A&E and tube already in place, so maybe just pass a bronchial blocker. Yeah. So probably the best thing is to pass a bronchial blocker, right? So if the patient is not intubated, you need to intubate that patient to isolate the lung. So good pre-oxygenation again, 3 to 5 minutes. Well-fit mask with the circuit, 100% 3-minute breathe during the minute or post-vital capacity. CBAB, breath support ventilation of 10 centimeter water or PB of 5 centimeter. This is all a way for pre-oxygenation intubation. Bag mask ventilation, 2% low pressure if needed, and then proceed to tracheal intubation. So tracheal intubation, do you anticipate difficult airway or predict I mean, do you think the airway unanticipated difficult airway? So you proceed normally. If predicted or known difficult airway, you do our intubation, as we said, which should be avoided. The unanticipated, to go for RSI, rapid sequence induction, with reoxygenation and acronym, succeeded either ETT and bronchial blocker or DLT. The easy is the one kind of bronchial blocker that have two elements, and you can block preferentially each one inside. Then the DLT confirmed position of bronchial blocker or DLT. Use a single-use bronchoscope for ETT or DLT with an embedded camera. There are disposable bronchoscopes, so that came in for use. So if we have this disposable bronchoscope, also we can use it. This is to highlight the needs for lung isolation. So there are absolute indication and there are relative indication. In the relative indication, there is high priority and the low priority. For the absolute indication, unilateral lung abscess or cyst, unilateral lung hemorrhage, bronchoalveolar lavage with saline to treat alveolar proteinosis, bronchopulmonary fistula, tracheobronchial injury, severe unilateral disease, lung transplantation. And for relative indication, the higher priority of pneumonectomy, tumor obstructing the main bronchial stem, thoracic aneurysm with cardiopulmonary bypass, lobectomy or lesser lung section, low priority intervention on the pleura and mediastinal structure, hysterectomy, orthopedic surgery on chest, thoracic spine surgery, minimally invasive cardiac surgery, bilateral cervical sympathectomy. So the ventilation and one lung ventilation for those with tracheal intubation COVID-19 is a high risk because of the aerosol transmission during tracheal intubation with either W tube or endobronchial tube and bronchial blocker. And during bronchoscopy itself, for confirming or managing the complication, to evaluate and manage the device. Intubation is also a risk for patients with severe lung disease due to COVID-19 who may not tolerate prolonged period of apnea. That's what Dr. Nagaran was saying, the two-hit model. So it's also applied here because those patients are like two-hit. They have a problem in the lung, which need an oncology attention, and also they have a problem with the lung due to the COVID. So this slide, it shows what the preferences according to the people who been asked whether a bronchial blocker or DLT. The lung separation tool preferably used by respondent for COVID-19 patients. And actually, I was surprised at the beginning. How come most of the people prefer to use the bronchial blocker, 52.4%, over the double lumen tube, which are the 42.9%. But then I thought about it actually. The rationale behind preferring the bronchial blocker is that the bronchial blocker is reserved for those patients who have difficult intubation or difficult placement of DLT. So why to start with a DLT if the patient is going to end with a bronchial blocker at the end? So the rationale is that start with the single lumen, intubation is almost always guaranteed, and put a bronchial blocker. But if they start with DLT and you fail, then again you have to intubate and use a bronchial blocker, which may prolong the procedure itself. Another antiviral filter should be applied to the end of the lumen. So to the end of the lumen of the non-dependent lung. So another filter, we disconnect the double lumen tube. One lumen will be open to the environment. We apply a filter on that. Always high, always try to oxygenate them well, 100% oxygen, low tidal volume, 4 to 6 ml per kg predicted body weight. Some degree of hypercapnia can be permitted, adjusting to the respiratory frequency and a pH of more than 7.2. Potentially higher PEEP may be required than that of a patient without COVID-19. Approximately even 13 to 15 centimeters of water may be reached. Patient may benefit from the application of alveolar recruitment maneuver, and a trial is recommended. CPAP into the non-dependent lung, two-lung ventilation, and all this failed, maybe go to ECMO. As you can see in this picture here, so this is the other of the inspirator and expiratory limb of the circuit. And then if you go here, see this is another filter between the circuit and the double lumen tube. And the double lumen tube, as the name carries, has two lumen, double lumen, 1, 2. So this, one of them will be connected, which will be ventilated the lung, and one will be disconnected. That's why that lung is not going to be ventilated. That lung, which is not ventilated, will have a communication to the outside. So we put a filter here. Normally we don't put. Normally we don't put filter. We just leave it open. But for COVID patient, it is needed to put a filter, another filter. That's why the number of filters is needed. So 1, 2, 3, 4, and during induction time, you will be using a face mask, and that face mask has to be also connected to a filter. So a total number, about 5 filters is needed if you have a patient coming for COVID instead of 2 that we normally use. Again, same mixture almost. Yeah, it's more clear here. This is disconnected, and then that filter is connected to the lumen, which has been disconnected. The only difference, this is a blue. So this is the bronchial lumen, and the other one is tracheal lumen. Yeah, that's the tracheal lumen. So this is in the tracheal lumen, and this is in the bronchial lumen here. A swivel connector. If we're going to use bronchoscope, we need a connector with a swivel nicely sealed for the bronchoscope. And this kind of bronchoscope are disposable, the one in the picture here. Disposable bronchoscope insertion through the suction port of the swivel connector, and a second generation supraglottic airway device, IGEL. This is very important. During this time, if the patient tolerates, we always should do the bronchoscopy while apnea and do it fast. If the patient cannot tolerate, we can ventilate the patient as long as the swivel connector is tight enough and doesn't allow good significant leak. In patients who are candidates for extubation, ideally those patients should be remain intubated if possible. Because it is a negative pressure room, it's not a negative pressure room, we want to extubate the patient. So best is to transfer the patient to a negative pressure room and extubate them. In patients who are candidates for extubation, it is suggested that gentle oropharyngeal suction is performed using a closed system. The patient should be able to extubate with a tight-fitting face mask to prevent airflow into the OR environment and should be instructed not to cough. Patients with a known difficult airway should remain intubated. Medication that lower incidence of coughing. During extubation, you want to use the medicine that lower the coughing reflex, and that includes dexmedetomidine or lidocaine. Use of N95 or surgical face mask. Once the patient is extubated, you want to give some oxygen through nasal cannula, preferably. And on top of that, actually, you can apply N95 or surgical face mask after extubation to prevent aerolization while oxygenating the patient. This graph for tracheal extubation. Tracheal extubation plan for COVID-19 following thoracic surgery. Is the patient still at risk of viral transmission? No, already intubated perioperatively. Yes, continue mechanical ventilation. So actually, we continue mechanical ventilation is for those patients who are at risk. Extubated, yeah. If the patient with a bronchial blocker, it's easy because we just remove the bronchial blocker and shift with the single lumen tube. If the patient with a DLT, what you will do? Two options. Patient with a DLT, you want to take to the ICU. Normally, we don't ventilate patients with the DLT. So either you relax the patient nicely and again put a single lumen tube, or if you don't want to re-intubate again, just pull the DLT until the bronchial blocker, the bronchial cuff in the trachea, and ventilate the trachea with the bronchial lumen. Of course, you need to deflate the tracheal lumen. So both of them is possible, especially for those patients who expect them short period of ventilation. But if you expect long period of ventilation, you don't risk putting the DNT. The idea of extubating the patient also just you need to have a closed section, also a closed circuit section, and also you don't expose the staff that are not regional anesthesia. We do regional anesthesia for mainly for in thoracic cases, mainly for pain management. So if you can do away without the regional anesthesia, like doing the IV analgesia, maybe better. But if you still can consider regional anesthesia, nerve block should be performed with ultrasound guidance to reduce the risk of local anesthetic system toxicity. Protecting it with a single-use plastic transparent cover can help to prevent contamination. Ultrasound probe should also be covered along the entire length with a disposable probe sheet. Additional analgesic block technique should be avoided if adequate pain management can be achieved using alternative regimes such as systemic analgesia. Moreover, because the severe acute postoperative pain represent the most important risk factor for chronic pain after thoracic surgery, quality of life pain management after surgery should not be disregarded even during current critical situation. So if the patient needs it, that's mean he needs it. You go for it. Okay, then we'll go ahead and solve the test. During COVID-19, regarding airway management, came across the mnemonic SAS? Yes or no? Still no? Yeah, correct. I think everyone knows now SAS. Bronchial blocker is the preferred tool for lung isolation by most respondents. I mean, it was a surprise to me actually at the beginning. Delaying surgery for a predominantly solid lung cancer more than 2 centimeters for more than 3 months is unlikely to have impact patient survivorship. It is likely to have. Using auscultation is preferred over bronchoscopy to confirm BLT placement. Actually, I didn't go through this. What do you think? Yeah, no, it's not the government. It's false. It's false. Actually, it's very difficult to use the scope, the stethoscope, while you are putting all the PPE. Extremely difficult. You have to take your things if you want to listen. So either the chest movement or bronchoscopy, preferably disposable one. So auscultation, it tends to be not good because it will force the people who listen to take their PPE most of the time. So the quality of the air entry is not really appreciated when you put your PPE. False. Okay. During providing GA for thoracic surgery, up to a total 5 HAPA filter required. Does it make sense? Yeah, it makes sense. Yeah. After extubation, do you apply face mask for the patient on top of this oxygen delivery device? Yeah. In the yellow zone, the one in the middle. Yeah, true. So the observer will be in the white zone. Good. Sounds good.
Okay, thank you very much for your presentation with these exercises and interaction. There is a little announcement just to remind everyone down their email.
Yeah,
please record. Okay, so we go ahead with the next speaker. We know this is chief of the Dr. Us on changes in perfusion technology during COVID.
Thank you. Assalamu alaikum. Good afternoon, all. Thank you, Dr. Ali, for kind introduction. Today, my presentation is going to be That's good. Presentation will be focusing on how we manage the COVID patient during bypass. So the outline is going to be just a light revision about the physiology of COVID-19 and management strategies, observation and challenges, points of caution and care, and the last point will be like a take-home message. As the last presentation shows that when COVID approached or started 2020, most of the elective cases has been postponed, and the cardiac surgery faces a lot of challenges while postponing the cases. As Dr. Ala says that if we postpone the elective cases, after 1 week or after a while, it becomes as urgency. So the COVID-19 causes a serious healthcare concern affected both healthcare professionals and the patients. The pandemic puts healthcare services, including the cardiac surgery, under the escalating pressures. This all was mentioned in the previous lectures. Challenges which face the healthcare system are caused by the uncertainty of the virus nature. So at the beginning, we know that the virus wasn't well known. So a lot of challenges we have made, and a lot of what we can say losses we face because of uncertainty of the virus. Delaying of elective surgeries would present cardiac surgical patients in more urgent manner that would lead to inevitable surgical decisions. So hence, preparation for such cases needs changes in our current modalities. So we'll have like a quick review about the nature of the virus. So the virus entering through upper respiratory tract, migrating to the bloodstream, binding to the heme group in RBCs, then rendering the hemoglobin incapability of oxygen binding, loss of oxygen transport ability, immunological response, cytokine storm, lung endothelial damage, fluid retention, and ultimately RDS or multi-organ failure. Now, in order to managing such patients, because at the end we have to treat the patients, we have to do the surgery, we have to expose patient under cardiopulmonary bypass. So we have to set a plan for such patient and set strategies to manage it. Now, the patient selection, of course, patient selection is, we have no choice. We have to take the patients to the surgery if patient needed. Then we'll go then for the staff protection, and this some points will go later one by one. Now, as I said, as patient selection, diagnosis differs from one patient to other patients. Like patients comes with valve cases, different than cavities, different than congenital cases. So we have to study, we have to take care of, know this patient very well about the procedure is going to be happening. Medical history also is very important. Before we start any case, we have to be careful about the patient's history. Dr. Khalid was mentioned about the patients with cardiovascular diseases or any comorbidity diseases will be more prone to have bad prognosis. Lab investigation also, we have to focus on coagulation profile, which we found that coronavirus like make the coagulation profile like not clear. Patient will go sometimes with the DIC or platelets imbalance. Age of the patient also makes play roles also. I think the third case which Dr. Khalid was presented was 80 years old, also high risk will be. Gender, we noticed that male more prone than female. Comorbidity factors, including the medical history and the weight also. Obesity also shows that high risk will be there. Now the staff protections, of course, we need to have well-trained staff when we have a COVID patient. This will be organized by infection control department, and we are going to follow the same guidelines which are the other departments following based on infection control guidelines, personal protection equipment, and that includes whatever we know that N95 mask, gown caps, and eye protections, and boots cover, and whatever needed. Now, before we start to pumping COVID cases, we have to know our items, the perfusion items. Now why we have to know our items, because we are providing the care through our items. So the ability of our items and know well what is our items and how to contribute with the better outcome is very, very important. So this is a list of some of important items, which is not all of them, but this is what we directly has impact on the COVID patient: oxygenators, the tubings with filters, a hemoconcentrator, the cardioplegia system, and the heater cooler, the auto transfusion machine, and the ACT machine, and balloon pump and ECMO machine. Now the oxygenator, we have to know before we start any the COVID case, we have to know what oxygenators. Now oxygenators is like artificial lung. It inhales and exhales. It's like lungs. So would corona passes through it? This is the question. If you go to the oxygenators, it's made of microporous polypropylene fibers. As so far now, there's no evidence shows that coronavirus can pass through these fibers. And as a precautionary method, vent scavenger is connected to the vent port to eliminate the vented gas. Now this is like a precautionary measures. So what we do to clear all possibility of aerosolization via microporous, if there is a chance of traveling the virus, so we have to scavenge it. If you notice that this is a black arrow, there's a tube. Usually in regular cases, we just keep it on. I mean, without any, it's like open. But for the COVID patient, we need to keep a scavenger with low section, just to scavenge all the vented air. So that will help in reducing any aerosolization during the bypass. More with plasma leak. All oxygenators, cardiopulmonary bypass oxygenators prove that there's no plasma leak before 6 hours. It made to stay for 6 hours. After 6 hours, there's a chance for plasma leak. So this is scavenger also might help with that. If plasma leak happens. The section kept in the gas outlet. It's safe and to use a vacuum. It's proven to be safe. There's no harm in using the vacuum. Should be less than -10 millimeter of mercury, but gas should be open. We should put in mind that if gas is open, we should use it. If the gas is off, then we have to switch it off. Now going to other topic, which is the we know that the cardiopulmonary bypass itself causes the systemic inflammatory response syndrome. In addition, that the coronavirus also has a main cause of the systemic inflammatory. So that will be that this patient will be exposed to be double, or I would say, systemic inflammatory response. So it's inevitable. We have to face it, but we can minimize it. We cannot eliminate it, but we can minimize it. So there's like different steps to eliminate the inflammatory response by using the hemoconcentrator. COVID patients are characterized by acute, as they said, that systemic inflammatory response, which lead to multi-organ failure. Studies show how level the pro-inflammatory cytokines, aggressive hemofiltration helps in eliminating the substances. Now, as I said, the only way to minimize the inflammatory response substances such as cytokines is the hemoconcentrator. We have to use it aggressively. We have to follow the cuff or even Z buff, that's zero balancing. So this is the only way. And other way is also I did mention here, but also I think Dr. Ranga was mentioned in one of the slides, biocompatibilities also. So all our custom packs, the tubes are exporting, which each company has its own substances, heparin-like, but not a heparin. It reduces also the inflammatory reactions. Now, if we go to a anticoagulation management, as also previous lectures shows that coagulopathy is happening with coagulation with the COVID patients, mainly clotting or thrombosis formation. So once patient exposed to the cardiopulmonary bypass, we know that patient will be exposed to the foreign surface, and we are using the heparin to anticoagulate the patient. So also the thrombus formation will be, the chances will be doubled also due to our circuit or due to the disease process. So anticoagulation management is basic factor for cardiopulmonary bypass. Patient must be fully heparinized, 400 units per kg as we are doing, or we might give also more dose. Monitoring every 30 minutes, our protocol, but we can make it every 20 minutes or even every 15 minutes. COVID patients are known to have, as I mentioned, coagulopathy. Can be treated with high dose of heparin. That can be, and watch also other coagulation factor, which is ABTT and AT3 and other coagulation factors. Eliminate or minimize a factor that might lead to thrombus formation within the circuit. So in our hand is taking the history, checking the coagulation profile. We have a background about also the preoperative anticoagulation, the medications also. During bypass, we depend on heparin, and some also we can induce also FFP if needed, and we are monitoring through the ASCPs. Going to the blood management during the surgery. Although lab studies reveal less than 1% of coronavirus transmitted by blood and blood transfusion, infection control and blood transfusion guidelines must be strictly followed. So we have to compensate also low oxygen transport. We are following our routine practice, which is low hemodilution, ultrafiltration, are using the auto transfusion cell saver, colloid fluids, and if needed, blood needed to be given, so we have to give. So ensuring high hematocrit, so ensure the oxygen transport to the patients. Going back to the auto transfusion, now the using of cell saver. Of course, we are using the negative section just to take the blood from the field. And it shows that this negative, using the negative section will lead to also aerosolization more because of the movement of the fluids, the movement of the blood. It causes the micro bubbles. That micro bubbles will exaggerate the growth of the virus. So that would be exaggerate the high vacuum pressure and ineffective filter. Our cell saver, like cell saver we use, is contain inbuilt vacuum system, which efficient filter. So provide a closed circuit, which minimize the effect of the effect of the corona on the patient. There's some points and coaches and care we have to take care of. Now we know that patients with corona will be with the low oxygen, so we have to watch the blood gases frequently and adequate oxygenation and CO2 removal. So reduce CO2 demand meets altered O2 supply physiology. The ABG result neutral or might be acidotic alkalosis, not recommended. So alkalosis also preferred to be more than acidotic. Hypercoagulability is also, we have to keep it in mind. So adequate anticoagulation and monitoring is also recommended. Maintaining the hemostasis. ACT or ABTT to be monitored along with the probe anticoagulation management. In ABTT, we don't measure it during bypass, but we can depend on the preoperative result and also they can see it in the ICU. Blood and blood parameters and platelets counts and 83 levels, and all pro-coagulant and inflammatory and septic markers, aggressive treatment and secretary to sepsis, if any. Now, this is 2 slides. I just want to highlight on this device, which we don't use it, but still it's been using in the other country. That it's called a CytoSorb. CytoSorb is a therapy and absorbed blood purification. It's like a filter. Use it for such cases. Technology that designed eliminate and elevate the level of the cytokines and other inflammatory mediator from the blood. It has an efficient character feature to eliminate and to take out the cytokines and all inflammatory better than regular filter what we are using. It intends to serve the adjacent therapy in systemic hyperinflammation by modulating the cytokine storm. Can be used in any medical condition associated with hyperinflammatory response. Any cases that expected to be with inflammatory responses can be used. So the device looks like a filter, but it has all this capability to remove all the substances, including some proteins also. I just pick up some literature which is supporting this device, and it was trialed and they used in COVID patients, and the result was improved. It's that most of patients will respond standard intensive care treatment. However, subgroups patient fail to improve. That group which not use this filter despite adequate supportive therapy progress more severe illness. In this population, the use of extracorporeal cytokine absorption appear to provide significant benefit. This is the extracorporeal cytokine removal. So take-home message is we as a healthcare professional should always step forward to face any kind of health crisis. Once the nature of disease is well studied, current treatment modalities must be adjusted accordingly. Multidisciplinary teamwork is proven to be all. Coronavirus still is. So I hope one day we can call it was. Thank you very much.
She's a senior consultant in adult intensive care unit at the Royal Hospital. She's also a fellow of the Faculty of Anesthesiologists of the Royal College of Surgeons, Ireland. She has a European diploma in intensive care, and she's the General Secretary of Oman Society of Anesthesia Critical Care. And I think she's the most experienced in COVID care amongst all of us. The topic is considerations of coronavirus infection from the perspective of an intensivist. Welcome, Dr. Julie.
Thank you, Chairperson. And thank you, Dr. Madan and the organizing team for inviting me for this wonderful enlightening conference and to be part of this. So my topic is the critical care perspective of COVID-19. So as we must have seen, SARS-CoV-2 infection, it ranges from mild asymptomatic infections in almost 80% of the patients who recover completely, don't even need to come to the hospital. Whereas out of the 20% who manage to come to the hospital or reach hospital for whatever reasons, 25% of them end up in the ICU. When you come to ICU, we have a lot. In fact, we have whenever what cancelling converting hot opening virtual care center. We have been able to wherein you use manage the critical. 18 to 8 apart from emergency what to the ICUs. COVID is a complex disease. It's a multi. The commonest reasons being your acute hypoxemic respiratory failure, which ultimately patient lands up into ARDS. Ideally, any patient who requires more than 10 liters of oxygen and is unable to maintain saturation more than 90% should be admitted to ICU. Again, because of our limited capacity, most of these patients were admitted in ambulatory wards, and we were constantly watching these patients. And in fact, we were involved in ambulatory as well as in ICU. So whenever needed, these patients were quickly brought into the ICU. Apart from respiratory failure, of course, we had patients due to other organ dysfunctions like renal failure, stroke, myocardial infarction, and shock due to various causes, including septic shock, which was the hallmark of our COVID patients. Now, looking at the ARDS aspect, you know, the ARDS was the commonest presentation of COVID patients. Now, the ARDS that we saw in COVID was a little different than what we were used to managing. Although the virus enters through the respiratory mucosa, but the major damage in the initial stages was in the vascular endothelium, and it is the release of these mediators which produce unrecognized hypercoagulability. And this hypercoagulability led to pulmonary microcirculation thrombi generations, and it was more of a perfusion defect than the alveolar involvement that we are used to managing when it comes to ARDS. So that's why we had two types of ARDS, as it was very well shown by Gattoni, who is considered as the father of ARDS, that there was an L type and an H type, that is 1 and 2. In type 1, as you can see here, the lung tissue more or less looks okay. This is the initial stages where you get the ground glass appearance, where there is less of alveolar involvement. Here, the problem is more of a perfusion defect, which causes the ventilation perfusion mismatch. Here, the compliance of the lung is very good. It's a very, very distensible lung. Here, if you apply the ARDS principles that you know, you might in fact end up harming the patient or pushing your patient towards the H type, which always has worse prognosis. So in type 2, again, you have a situation where the alveoli are infiltrated, there is edema in the alveoli, and the aerated tissue comes down significantly, and the compliance goes down. So this is the typical L and H type. So in both these patients will present with severe hypoxia, but in the L type, where the compliance is good, the patient will be severely hypoxic and will be looking fine to you. That's the famous happy hypoxia that we have heard. So here again, as we have seen, it is mainly due to the perfusion defect, and the H type where the CT will show more of consolidations. And here again, there is a more risk of ventilation induced lung injury if you don't manage this situation properly. So all the time we need to keep this in mind when we are supporting them either with an invasive or a non-invasive ventilator. So initially when the patient is coming to you, the patients are tachypneic, desaturating, and they are like taking very large tidal volumes. That is the time when your alveoli at the first stage are at a risk of over distension, and it leads to what is called as patient self-induced lung injury. And this leads to atelectrauma, increase in the vascular transmural pressure, and can push the patient into pulmonary edema, into alveolar edema. On the later stages, again, because of the increased respiratory efforts, there is an increase in the pressure on the alveolar wall, and that again, with the leaky capillaries and the leak in the alveolar epithelium, again, there is increased fluid infiltration into alveoli, protein collection, and this is the time when the alveoli are difficult to open up and the compliance goes down. So here again, your ventilation strategy has to change. So before intubation, again, your objective is to achieve adequate gas exchange. When you say adequate gas exchange, you don't want more than 90% saturation. But that adequate gas exchange should be achieved without any lung injury. So what are the options available? You'll be initially giving them with supplemental oxygen. Later on, you'll be giving them CPAP support, NIV, high flow nasal cannula. But what is important is if at this stage the patient is not responding, you should encourage something called as await proning. You allow the patient to prone themselves and improve the ventilation perfusion matching. At all times, you should avoid heavy respiratory excursions on the patients. Again, if you're ventilating the patients, avoid large volume ambu bagging to avoid injury to the lung and avoid ventilation induced lung injury. The PEEP should be minimum at the initial stages. The tidal volume should not be very high, but should not be very low also in the initial stages. Again, you maintain acceptable gas exchanges, maintain your fluid balance, avoid fluid overload, reduce the oxygen demand if necessary by sedating and ventilating them, and minimize your transpulmonary pressures. After intubation, again, the focus should be in the L stage, you use lower PEEP. That is in the initial stage, PEEP to the extent of 10. The tidal volume strategy should be of 7 to 9 ml per kg rather than the low tidal volume strategy that we are used to in managing all ARDS patients. Believe me, all these patients will have PF ratios of less than 300 sometimes or less than 200. That is, they might be into moderate to severe ARDS. But you don't have to go to that ARDS strategy of using high PEEP in the initial stages because you might be doing more harm. Lower tidal volumes are unnecessary. Higher PEEP is also ineffective. If you give high PEEP, what will happen? You might be compromising the circulation and increasing the shunt fraction. And that is the main pathology in the initial stages. So we need to be careful about that. Again, at the time of weaning, you need to keep these spontaneous excursions in mind. If the patient is not ready for weaning, or even in the stages where the lung has not healed completely, if you allow the patient to breathe spontaneously, and if he ends up taking larger tidal volumes, you might again cause more harm to the patients and push him towards the towards the H type of ARDS, and it might end up having late stages where the recovery might be impossible and patient might go into the fibrotic stage of the ARDS. So, as we have said, initially you give minimal oxygen needed to maintain 90 saturation, use your non-invasive ventilation, and later stages use your strategies for your H type of ARDS like low tidal volume, target your plateau pressure less than 30, target your driving pressure, that is the difference between your plateau and the PEEP, to less than 50, and never have a goal of higher than 90 saturation. Use your prone position to improve your ventilation perfusion matching. In some situations, nitric oxide has been helpful as a rescue therapy. And last but definitely the least is your, not the least is your ECMO therapy, which unfortunately we could not offer to any of our patients. Now coming to non-invasive ventilation, it was an initial measure which was recommended for all the patients, although it was a weak recommendation due to low quality of evidence. But it did help quite a few patients, especially during the first wave. But what is important is to avoid the self-induced lung injury in the patients. And if you see very large tidal volumes, then that is the time you might need to consider early intubation. And the decision to intubate this patient should be well in time, because the failures of NIV, we have noticed that almost 60% of these patients who failed NIV ultimately develop the end stage ARDS, go into the fibrotic stage and never recover. So that is the problem with, but overall in the initial stages, NIV is useful and it has provided survival benefit. At one time, because of this failure of NIVs and leading to higher mortalities, we were all very reluctant to put NIV in these patients, and we thought that patients should be intubated as soon as we see them, and that was the trend that time. Not that intubation always offers a better survival all the time. 50% of those patients also ended up dying. But this systematic review allayed our fears, which was really released on 25th March, which said that early or late intubation does not affect the outcome. So NIV should be offered provided you are watching the patient closely and avoiding self-induced lung injury. Other issues were with NIV were the aerosol generation that you see. Everybody was worried with NIV. You might be causing more aerosols and you might be infecting the staff, and so people were very reluctant to put patient on NIV. Again, that was taken care of when a study published showed that NIV produced droplets which are like more than 5 millimeters. It's not an aerosol. So definitely if the staff is wearing a full PPE, then the risk is almost negligible. So best is always to manage these patients in a negative pressure rooms or a neutral pressure rooms or dedicated wards for COVID patients. But having said that, with full PPE protection of the staff, we have managed patients in the normal wards as well with full protection. What is important is to use antimicrobial and antiviral filters, which will limit the exhaled air's dispersion into the surrounding environment. And to avoid your SILI and VILI, that is your ventilator-induced lung injury, we need to closely monitor the tidal volumes. Any patient who reaches about 12 ml per kg tidal volume and is tachypneic and maintaining even enough oxygen, that patient you really seriously need to think about intubating them early rather than allowing him to continue. Because the patients look so well on that NIV that you don't have a heart to intubate them. But more often than late, we end up damaging their lungs, and sometimes it's too late even if you end up intubating them. Patients sometimes are not very compliant with NIV. So this can be taken care of with the big array of interfaces that we have. That is your helmet, mask and all, which have shown better compliance with the patients. Again, it's a learning curve. Many of us were not comfortable using that, but some centers in Italy and all have had wonderful results. And it should be considered whenever the patient fails NIV with a normal face mask. So coming to the NIV and a modality, that high flow nasal cannula. Most of our patients, we did give them high flow nasal cannula, and many patients did well. It provides lower transpulmonary pressure, resulting in less lung injury. And the normal other NIV that you use, the bi-level NIV, because of the high level of pressure support with the inspiratory efforts, it increases lung injury, and hence high flow nasal cannula is more recommended compared to the other NIV which we use with the pressure support. Now this high flow nasal cannula with prone positioning gave much better outcome in the patients than NIV as it has been seen in many studies. Proning with NIV, irrespective of the interface that you're using, whether it's face mask or your helmet mask, proning was totally achievable. We need to do minimum 3 hours of proning with a break in between, and then again encourage the patient to breathe. Because as soon as you make the patient supine, you will lose that oxygenation benefit that you're getting with proning and the ventilation perfusion improvement. So proning has to be totally encouraged whenever you're using NIV. In fact, when patients cannot prone themselves, they have found out that positions like tripod position, which is the best position when it comes to recovery from lungs. Safety issues have been addressed by all the studies, and in fact, all the guidelines, be it of NIV, there is minimal risk of aerosol generation, If you use proper filters, the environmental contamination is also minimal. What is important is to remember a clear indication. So patients with and contraindications, patients with worsening respiratory status, hemodynamic instability, multi-organ failure, or altered mental status, obviously those patients are not to be considered for NIV, and we need to closely monitor for failures in these patients. CPAP is a preferred mode than the pressure support ventilation, again to avoid larger tidal volume generation, and we should have realistic aims on this. So ultimately, when patients do end up getting intubation or go towards the H stage of ARDS, the rescue strategies which we have been used to managing from before stay good here as well. That is your low tidal ventilation of 4 to 6 ml per kg of predicted body weight, target plateau pressure of less than 30, prone ventilation for 12 to 16 hours for any patient when the PF ratio is less than 150. Should be considered for proning. All of you must have had, whoever has worked in COVID ICU has had tremendous experience of proning. I don't think we are ever going to forget how to prone a patient after this pandemic. We have ended up proning even pregnant patients up to 28 to 32 weeks with excellent results in them. There are risks associated with it, but they need to be monitored very closely, but they have shown very good results. So proning is totally recommended for all these patients. And the learning curve is very small. It takes only probably half an hour to learn how to prone the patients. Inhaled nitric oxide, we did use it in a few patients, but we didn't have any promising results with that. ECMO, again, because of the logistics issue, we couldn't provide to any of our patients. But probably in near future, we might have to consider this if we end up having these patients again. So coming to other aspects in ventilation, this patient is to avoid environmental contamination is to use closed suction circuits so that open suction is totally avoided, and good supportive care like a good physiotherapy team, good rehabilitation team is what is going to improve the outcome in all these patients. Cardiovascular manifestations we have seen in detail with other presentations, but about 35% of these patients did come up with shock. But what is important is that this shock is not only due to the heart per se, the lung involvement, that is the hypoxemia and the dead space, leads to the rise in this pulmonary vascular resistance. And most of these patients present with right ventricular failure, which is followed by the left ventricular failure, and this needs to be kept in mind. And the other causes of pulmonary in these hypoxic patients, that is your acute pulmonary embolism, was again very frequently seen and should be kept in mind whenever you face with a patient who suddenly becomes hypoxic in the unit. So sometimes when you're not very clear whether it's a right side failure, left side failure, again in COVID patients as well, advanced hemodynamic is recommended, but because of the resources and the logistics issues and the personnel issue, we do struggle to put these patients into this advanced monitoring, and we rely on the standard monitoring facilities that we have. Hemodynamic support very. The combination to raise the MAP or to reduce the dose of vasopressin or to reduce the dose of your norepinephrine because of the peripheral ischemia and the peripheral gangrenes that we see sometimes on the fingers. Dobutamine should be used whenever there is cardiac dysfunction or your patient is not responding, your MAPs are not improving with your vasoconstrictors alone. We have to suspect myocardial failures in this patient. Refractory septic shock, in spite of all your inotropic and the vasopressors, if the patient is not improving blood pressure and the patient is in full-blown septic shock, and even after patient has finished the 10 days course of dexamethasone, which is recommended, you can start your low-dose steroid, which is recommended in the shock, and it's most of our patients did end up receiving them. Refractory ARDS with refractory cardiogenic shock, again, after all your standard supportive care, if they are not responding, ECMO is recommended for this patient. The other problem that you face in your COVID patients is your highly catabolic state that we see because of the extensive inflammatory condition and the cytokine storm. So nutritional support becomes very important. Either enterally or parenterally, the nutrition should be provided to these patients and as early as possible. Blood glucose should be monitored very closely and should be maintained around 10. And most of these patients do need insulin irrespective of their diabetes status. In fact, insulin sometimes has been shown to improve the cytokine storm in these patients and improve recovery in these patients. Other supplements like vitamin and trace elements should also be provided with the feeding, and balancing electrolytes is most important because of the arrhythmic potential all these patients have. Coming to acute kidney injury and renal replacement therapy, 20% of our patients ended up having acute kidney injury. And although by the time they develop acute kidney injury, most of them would be on inotropic support. So continuous renal replacement therapy is the recommended option. But however, if it is not available, there are centers where patients are managed with intermittent hemodialysis, but you have to do slow dialysis over longer periods of times. Coming to specific therapies for COVID, we know that the options available are your antivirals, your immunomodulatory drugs, steroids, anticoagulants, and the antibiotics. Now, when you look at the trajectory of the illness, the first week is your viremic phase, where there is a lot of viral replication is happening. So what kind of drugs would you use in your first week? Antivirals, correct. And the options are your remdesivir. Currently, that is the recommended drug. However, in the later stages, that is your second week or 8 days onwards, you enter into the inflammatory phase where there is not much viral. The virus has already caused damage to the endothelial structure, and you have a lot of cytokines that are released, and you are facing the cytokine storm. At this stage, would you give antiviral to this patient? No. Yeah. What about the hydroxychloroquine and ivermectin? What class of drugs they fall into? They're all kind of antivirals. They are called repurposed drugs. So they are used for something else. Now they have found to have some antiviral properties, so they were being used. Even those you will not give in the cytokine storm stage. If at all, it has to be considered in the first week. Again, currently we are not recommending any HCQ or ivermectin, but I'm sure there are some parts of the world who are continuing to use these drugs, and we have to wait for the evidence to come up with that. So in this inflammatory stage, you will be using drugs which are anti-inflammatories. So the common anti-inflammatories or the immunomodulatory drugs that we use are, any guesses? Steroids, yes. Tocilizumab, yeah. So these are the two drugs which has been used extensively, and there are well-documented studies for this. So if the patient is hospitalized but does not require oxygen, what would you give to this patient? He is hospitalized but does not require oxygen. Would you give steroids? No. Would you give antivirals? Yes. Yes. First week. We are still in the first week, so we'll give. Would you give tocilizumab? No. No. You may consider. So again, we'll see how we'll come to that decision. If the patient is hospitalized but requires oxygen, he is hospitalized and now he is requiring oxygen, supplemental oxygen, increasing requirement of oxygen. What would you give at this stage? This is the stage where you give your antivirals, surely, your steroids. Okay? Steroid and your antivirals works best once you have oxygen on board. Okay? When you don't have oxygen on board, you don't need steroids. Nothing you need. In fact, you need only supportive care. You may, some places do consider antivirals, but again, that is not recommended. But once you require oxygen supplementation, definitely you need steroid. This is the stage. You are going to cut short your cytokine storm here. Okay, that is the beginning of your cytokine storm, and it is the time when your viral replication is also happening. So you will use antivirals and steroids at this stage. Okay, once the patient requires oxygen. If he is hospitalized and requires oxygen through a non-invasive ventilator, now you are giving now ventilatory support to these patients. Definitely here is the stage you will consider tocilizumab. Now, why we are saying consider, there are centers where they don't use any tocilizumab. Okay, not that their patients don't improve, but if you have, and there are places where they want to use but they don't have it, still the patients do end up improving. So it's a very confusing disease. Okay, So you don't know which way your patient is going to go. But if you have it, the evidence says, although it is not a class 1 evidence, but if you have it, this is the stage you will use your ventilation or ECMO. He's reached the stage where he is very sick now. So what will you give here again? All except antivirals. Yeah, very good. And dexamethasone, if you have finished the course of dexamethasone, already 10 days over, would you give more steroids here? You can consider, but not totally recommended fully. So you have to see on a case-to-case basis. You might consider to prevent the fibrotic stage of ARDS and all. Again, there are two schools of thought. These are not class 1 evidence. So even if you say you will not give steroids, you won't be wrong. Because the problem of giving all these medications is they are all immunosuppressive. So you'll be exposing the patients to infections. So it's a no-win situation for the patients. So one thing that can guide your therapy is your biomarkers. Your standard biomarker like CRP, which is very cheap, easily available, is something which can be relied upon to some extent in our patients. So CRP, whenever you have patients with viral infections or atypical pneumonia, you won't have very high CRPs. If you have typical bacterial infection, the CRP will be very high. But if the CRP is up to 72, in fact, they recommend using tocilizumab. The patient is like having, that means it shows there is no bacterial infection sort of, it has not yet come in and patient has gone into cytokine storm. So 72 is considered kind of a cutoff. Cytokine levels, we did cytokine levels for many of our patients, the interleukin 6, and it was used to guide our therapy with the immunomodulators, that is your tocilizumab. But again, it's not a must. It's not necessary to do interleukin levels. If your patient is having clinical manifestations from cytokine storm that you have seen in your first lecture, then definitely you can give irrespective of the interleukin levels. However, interleukin level more than 24 in one study was heralded as the onset of cytokine storm, or it predicted that your patient is going to become severely hypoxemic and you can give this. Another biomarker is your procalcitonin. Your procalcitonin again tells you that your patient has viral infection, and more than that, it doesn't tell you exactly that you're viral, but it can tell you that it doesn't have bacterial infection yet. So the cutoff is your 0.25. If your procalcitonin is around 0.25 and your patient is sick, having all viral symptoms, then definitely patient has viral infection. Above 0.5, it becomes difficult to decide. Between 0.5 and 2 is a stage where your patient could be having cytokine storm or might be getting into the bacterial infection also. So this is the stage where you might consider adding what drugs you will add here when the antibiotics here. Okay. Otherwise, antibiotics are not recommended in viral infections. Okay. What is the problem if you use antibiotics? If you use in viral infections or when there is no bacterial infection? Resistance, antimicrobial resistance, which is what we are fighting even since longer than the pandemic actually. Correct? So we need to keep that in mind. So if it is above 1 or above 2, definitely you will give antibiotics. Between 0.25 to 5, you have to look at the other factors, whether you need to give antibiotics. But below 0.25, definitely no antibiotic. So a combination of biomarkers sometimes helps you rather than a single biomarker. Again, if you don't have procalcitonin, you can go by clinical presentation. These are not mandatory, but if you have, you will use these tools to guide your therapy. So for your tocilizumab, there have been 2 randomized controlled trials which have clearly shown a mortality benefit with tocilizumab, including patients who present with rapid respiratory decompression along with an inflammatory response. So they incorporated patients within 24 hours of having some respiratory support, like either high oxygen, high flow nasal cannula or NIV. And in fact, they showed that at that stage, if you use tocilizumab, you might be able to avoid invasive mechanical ventilation in these patients. So again, the timing is very important. Both this REMAP and recovery trial have shown good mortality benefit and reduction in the number of intubations and ICU. Steroid has been proven without doubt by a major study from the UK, which was a recovery study again, which showed that using dexamethasone 6 mg for 10 days has significantly reduced 28 days mortality. However, if you don't have dexamethasone or if your patient is getting some other steroids, you don't have to give dexamethasone along with it. You have to consider other drugs like methylprednisolone 0.5 milligram per kg twice a day, or other options like dexamethasone 20 milligram once a day for 5 days, or 10 milligram once a day for 5 days. So you might use other regimens. But if you are giving steroids for some other reason, like say you're giving hydrocortisone 100 TID to a patient for asthma, you obviously don't have to give dexamethasone along with it, and that's what we need to remember. We have already discussed this. The other immunomodulatory drug that we used, any idea? Interleukin-1 inhibitor, that is your anakinra. Again, they all work in the same way. Again, you will see that different types of patients respond to this immunomodulatory drugs, because even COVID has different phenotypes. So that phenotype which shows intense inflammation, which is manifested by high levels of these markers like IL-6, D-dimer, CRP, LDH, and ferritin, they are the ones who will respond to these drugs better than the other kind of patients. Antithrombotic therapy, again, initially when COVID came in the first wave, we started using therapeutic anticoagulation because definitely hypercoagulability was well established with COVID. Again, as we learned in the process and more studies were done, we realized that high dose of anticoagulation is not benefiting and may increase the bleeding risk and other issues with the patient. So currently what is recommended is prophylaxis for all. And if you have evidence of hypercoagulability like a PE or ischemia anywhere else, then only you give full dose therapeutic anticoagulation. Okay. So there are lots of guidelines. This is another guideline available. Last but definitely not the least, we have to look at the ethical dilemmas that we faced in the ICU and all over the hospitals during the pandemics. Because COVID-19 pandemic required increased number of resources, reinforcement of the ICU teams with new staff members. You had to work with people who had no experience of ICU, but you had no choice. You wanted them also, but still you had issues with them. So those kind of issues were manifested in lot of mental health issues and psychological issues and ethical dilemmas and safety issues in the ICU. And again, and plus the COVID management protocol kept changing every day. So even if you are experienced in working in ICU, you yourself needed to be mentally prepared to this changing world every day. So it led to a lot of moral dilemmas and ethical conflicts with lot of communication issues because of the PPEs and all. And that led to a lot of stress and burnout among all the staff. And in fact, there was a total loss of control over the professionals in the COVID ICU, and that had to be managed along with the medical management of these patients. And that's why you needed a good psychosocial support, which is a must in all pandemics, you know, when you're managing this kind of patients in the hospital, along with the team support. And only then you can improve the quality of care for these patients. Just by having these drugs and resources is not enough. The other kind of support system is equally important. So the key aspects are, what is important is to identify this high risk, the patients who are going to deteriorate, and to ensure that the ICU facility is available for these patients in the timely manner. The initial management is always with your conventional oxygen therapy along with your non-invasive supports. Those requiring invasive ventilation, lung protective ventilation still stands the test of time. Cardiovascular complications are frequent, and they include all kinds of cardiovascular events, as we have seen in many of the lectures before. What all the therapies have been tried, most of these therapies are still experimental. We don't have full evidence for all these patients, so everything has to be taken with a pinch of salt, and no two patients might present in the same way. So every patient has to be assessed for using these therapies. However, simple therapies like steroids and heparin have stood the test of time and remain the main supportive therapy. So until we see a definite anti-COVID drug and a vaccine rollout becoming successful in all parts of the world, the mainstay therapy is your standard ICU care. With that itself, more than 50% of the patients will survive. Okay, that's what we have to remember. Thank you.
Thank you very much, Jyoti, for your interesting lecture. No, I will have time for this crisis. Thank you very much.
Thank you. You all have supported us. I think we all did it together. It was really good achievement for all of us. I think we all need a pat on the back, everybody.
The next speaker is Ishaq Al-Amri, Senior Consultant Cardiologist and Nephrologist. Ishaq has just recently joined us. His main interest, is 3D echo, point of care, hemostasis. RIS, I don't know what is happening.
Which one? Yeah.
And simulation.
Medical. Assalamu alaikum. I'm Ishaq Al-Amri, one of the anesthesiologists just joined here in the cardiac center. I was trained in Canada. I did my fellowship in adult and pediatric anesthesia. One of my interest things is medical education, especially simulation and postgraduate education. Today I will talk about the impact of COVID-19 on surgical training. I will focus mainly on surgical training, as anesthesia is part of the surgical training specialties. All we know is that fellowship and residency is a planned period or duration that is usually take 4 to 6 years for surgical specialties, residency, and 1 to 2 years for subspecialties. And there is a completion. At the end of the fellowship and residency, and to fulfill the criteria, you have to do multiple things, including surgeries. I have no conflict. My outline, I will go through introduction, COVID-19 and healthcare worker. Residents and fellows are a healthcare worker as well. Risk factors for SARS-CoV-2 infection in healthcare workers, and the impact of COVID-19 on different aspects of training, including teaching, research, mental and financial aspects. Then take home messages. Medical education, particularly surgical training, has been affected by this pandemic worldwide. Challenges and uncertainties faced by the trainees during COVID-19 infection is there every day. Trainees ask themselves, what next period I'm doing, where they will redeploy me. Is this pandemic going to finish and end? Are we going back to full surgical list, or are we still doing only emergency surgeries? And for subspecialties especially, there's a lot of elective surgeries that was cancelled. We need to support the health and well-being of residents, fellows, as well faculty members and patients. This is for the last week. Till the last week, we have 4,840,000 deaths, unfortunately, because of this virus. Where we are now, where we are today, we still have people dying every day, 8,200 daily deaths worldwide. Maybe it's not here, maybe somewhere else tomorrow. It was here before the pandemic. It's like it's traveling from one continent to another continent. I was talking about Australia, where I have a friend there. They have nothing. They have no cases. They had the vaccine a little bit late, and now they are the one who are also fighting with the Indian variant, which you say they isolated themselves and everything, but still it's going everywhere. We have 237,000 cases, 37 million cases that were reported. Unfortunately, this is underestimated. The actual number could be probably 3 to 20 times more. The risk for infection is about 4.2 to 17.8 times more than normal population in healthcare workers. 4.2% were recorded in China, 17.8% were recorded in Italy. Italy, they hit the record. Nobody, hopefully nobody will go beyond that. A meta-analysis of 97 studies showed that the prevalence of infection at 11% using PCR and 7% using antibodies testing. So still, even we have the prevalence, we should know it's plus minus 3 to 5%, depends on the test we are using. This is at the beginning of the incidence, but today we have a lot of people have antibodies after having vaccination and having the infection. In New York last year, it was a disaster where there is almost like 100% occupation of ICU beds, where the army came and they had a field hospital, a very huge ship as a field hospital. At that point, there's multiple, there's like thousands of people die every day at that point. There's a lot of residents and fellows got infection, and one of the studies was done in New York. They found the incidence of infection among trainees is almost about 20%. If you work in New York, 20% you will get the infection. The risk factor to getting the infection, if you are at trainees, if you are training in the emergency medicine, anesthesiology, and critical care, they found that if the resident get posted in unfamiliar hospital or environment, for example, in non-training site where they have no experience, it's not considered as a risk factor to increase the infection, although it's not allowed by most of the training sites. If we can see here, age, gender, and healthcare worker role, nurse, trainees, or physician is not risk factors for transmission at work for healthcare workers. The risk factors here, which has a strong association where race and ethnicity, black versus white, the direction or intensity of contact, if you have more contact, for example, airway or aerosol producing procedures, participation high risk, also surgery. This is high risk factors. As all we know, having PPE equipment is one of the negative association that reduce the infection. So the ACGME, which is accreditation of American residency and fellowship bodies, it classified the stages of effect of COVID-19 on the residents to 3 stages. Stage 1 is business as usual, like there is no effect. They do all the training sessions, all the lectures. The residents are doing their surgeries, daily activities, and they following the accreditation requirement. Stage 2, there is increased COVID-19 cases, but there's manageable clinical demand. Sometimes maybe once a week, there is a resident going to help in the ICU. There is little bit like 30 to 20 to 30% reduction in cases, but they are operating. So the program directors and the people who are responsible for training, they should have increasing clinical demand guidance, which I will explain next slide. The last stage, which happened in Italy and happened in New York, where there is nothing called trainees. Everyone has to work hardly in this pandemic. It's extraordinary circumstances. And all the residents and fellows, their training will be paused at that point. So the increasing clinical demand guidance, which is recommended, one is adequate resources and training, appropriate infection protection for clinical setting and situations. All residents, fellows who are coming to the ICU or to anesthesia, for example, or emergency, they have to get teaching how they use PPE equipment, toning, doffing. The session has to be done. Sometimes there is some places where they do videos requirement to be done by the residents and fellow. Then they have to do a test. Then they have to get the proof they did it. Then after that, they do it one-to-one with one of the infection control personnel. Unfortunately, still, this is not the thing in training residents and fellows. One of the a questionnaire was done in Saudi Arabia, there is only 43% of residents and fellows who get trained on TB. Adequate supervision for the clinical circumstances and for the level of the education and experience of the trainees. Sometime in New York, they at one point they don't have PPE equipment, so there is only one PPE equipment for the surgeon. It could be a fellow or it could be the staff. So sometimes this will be a little bit difficult in such situations, but it should be not there if we are in the intermediate phase or in stage 2. Work hour requirement is not recommended to do more than 80 hours per week. It has been seen there's evidence of increase in medical errors, needle sticks, and other adverse events that might lead to lapses of infection control. Fellows functioning in core specialty is very, very core specialty, which is a very specialized fellowship. They recommend to not go less than 20% of the annual education time in any academic year, but still I think it's very low if you do 20%, which other fellows were doing at the other years. For the academic and the clinical activities were affected in the first 6 months of the COVID-19. Then after that, the people adapted with virtual learning, lectures, and simulation. Elective cases were canceled. Especially, we only were doing the ER, emergency, trauma, or oncology, high-risk oncology patients. And this is where it comes that the number of cases per year were reduced by the trainees. Surgery that may require ICU bed also reduced because the ICU bed were occupied by COVID-19, and high-risk patients like cancer, they're already immunocompromised. You cannot keep them in one ward together, except if you have a specialized ICU. In some of the training specialties, they have to do a number of cases as a high-risk patient with complex surgeries, and this require ICU beds. So at that time, sometimes it's prolonged from 6 months to 1 year. In some places, they don't do any cases at that period. Even the relaunching phases, there's increase or reduced volume. Some of them, they went only to 25 capacity, some of them to 75 capacity. Still, it's not standard, but it depends on the place and it depends on the prediction of the infection. Even sometimes they go to 75%, and after 2 weeks, they go to 0%, only emergency because of the relapses, because this pandemic is unpredictable. One of the most unique consideration is the duration of the training and the level of the trainee. In the first period, people, they think maybe 3 months to 6 months would be enough. But after that, they thought this pandemic is lasting years. Maybe it will go beyond 2 years. Some of the fellowship that is only for 1 year, they got affected too much. They have reduced cases almost like 15 to 25%. And in very specialized fellowships, sometimes they have more than 50% reduction. With the residents who are most senior, R5, R4, because at the senior residency, they do more cases, so they are the ones who are more affected. They do less surgeries. This is in New York, they did one study. They compared the number of cases they did from 2016 to 2020. And then when the pandemic started, 2020 to 2001, March to March, they counted the number of cases the resident did. This is for anesthesia residents. They found there is a reduction about 29.8% in the total number of cases, so 30% reduction in the total amount of cases, 35% reduction in the theater cases. The day cases, mainly the day cases, which is about 46% reduction. They did more very sick patients, ASA 4 and 5. This is definitely because they do more emergency and urgent cases. Research is a very important aspect of training. There is some programs, it's mandatory, and residents or fellow have to present in local, national, or international conferences in some places. Clinical research was suspended in multiple places as part of the healthcare system's emergency response. Research type and the research stage is very important parameters that minimize the interruption of research with some fellows. In retrospective studies, usually there were no cancellation because you're only taking data. And in prospective studies after data collection, also there is no interruption. Only in the research that need direct encounter with the patients and researchers that need integration with the system. Although on the other way, there is a huge amount of increase in literature about COVID-19 publications. So it's good that some residents, they switch their research area to COVID-19, and that will compensate with some residents who are working in the ICU. Simulation is implemented in multiple surgical training programs, which provide a friendly and safe environment for teaching and learning and maximize operative encounters. Simulation boot camps is a very important aspect that a lot of universities in Europe and North America, they start 1 to 2 months of intensive simulation boot camp, where the junior resident gets to learn a lot of procedures in a safe environment and friendly, like in anesthesia, they do even intubations, ultrasound skills, IVs, art lines, epidurals, spinals, putting central lines, swan guns. This all can be taught in simulation. As well, high fidelities boot camp, especially ACLS, PULSE, and NRP boot camps. In-person simulation was suspended in multiple places as a safety measure and due to shortage of personal protective equipment. In some surgical programs, even with strict PPE protocol and they opened the simulation center, even they limited the participant number, still there is reduction. About only 56% of trainees had access to the simulation. We have only like half of the residents can get access to the simulation. So some of them, they adapted by having a restricted amount of number in the simulation, and then they were doing virtual simulation. Like they have the camera inside the simulation, and people watch from outside, and they do the discussion and debriefing all together by Zoom or by any of the virtual meetings. Virtual simulation increased the use of wet laboratory for technical surgical practice, this is anatomy labs with cadavers, use of live videos and take-home simulation kits for certain procedures were alternative things to simulation, in-person simulation. One of the major simulation is for the pandemic is how to manage cardiac arrest in COVID-19, how you do PPE. And this is the problem. Once they closed the simulation centers, what some centers they did, as a preparation for the pandemic, they trained the residents and trainees and even the junior nurses. They evacuate one floor because they stopped the admissions for electives, and then they put it as a simulation center. And they did only ACLS boot camp and PPE practice for everyone. So they can shift nurses from the wards to the ICU, and everyone has a request to do the PPE before courses before they work in the ICU or emergency. And anxiety and physical support is one of the parameters usually is ignored during residency and during the fellowship. Fear, anxiety, and depression were reported among healthcare worker professionals working in COVID-19 hospitals. Medical staff work in first line units, especially emergency, ICU, and ID showed twice more likely to have depression and anxiety than other medical staff. And I think it will be more than population, general population. Anxiety and depression symptoms were reported among trainees, 65 and 73% respectively, at least one symptom of each in training. Mental and health support is very important, and bodies that are responsible for programs, training programs, they should have 24/7 support for the residents. They should have psychologists or mental health physician or specialist that is responsible only for trainings. And in a lot of countries like UK, North America, they depends a lot on international medical graduates with residency and fellowship. And immigration rules and processing time of visa differs with COVID-19. There is particular type of visa required before you work in some countries like UK, United States, or Canada. Some of the programs requested their fellows to extend their training for a few months to compensate for the volume of cases and missed duration of training. And this is make a big problem because the reapply for visa extension would take more time. Even some of the immigration offices in these countries already they wrote in their website, their processing time will be like 140 to 180 days, which they have to leave and come back again, or it is a very complicated issue for them. Also, it is a very complicated for new trainees who are coming there, especially in the first 6 months, the pandemic was not clear. So there is a lot of places where there is a lot of residents and fellows, they didn't start their training because of the visa and immigration problem. On the other side, one of the things that increased the anxiety for these people, because these immigrants, they are immigrated from their countries. Some of them, they stay 2 or 3 years because they don't want to go back, and then they have travel restriction, they have delay in their programs and training, and they get stuck in the place they are training with for a while. Financial hardship with COVID-19.
What did they do?
What did they do? So there is multiple things. In some places they did express visa, like in Canada they did express visa. You apply. Once you apply, if you apply, you are legal. So you have to have an application before that. For financial hardship, there is economic crisis because of the COVID-19. Financial hardship is almost also in some countries where they are oil producing, especially with the dip of the oil barrel price. And at the same time, there is the fellows can be sponsored locally or by their government. The departmental funding, surgical assist billing, and industry-sponsored salaries can be affected by multiple factors, mainly surgical volume reduction, because some of the fellows, they're doing a lot of works, clinics, at the same time they do some training, but they do a lot of other works. And this is an income for the hospital. So they have like a pooled system where they get this money and distribute it for the fellows. If there is no surgeries, that's mean the fund is interrupted, and some of them they have to terminate the fellowship, or they have to stop the fellowship for next year till things settle down. Extension in the training may require extra funding, and this is a problem with the trainees, a problem with the personnel who is funding. Take-home messages. The COVID-19 pandemic is a global crisis that has had an impact on global healthcare system and training. Virtual clinics, teaching, and simulation can play a role in such pandemics to minimize the impact of COVID-19 on training. Minimum requirements should be revised before the completion of training, because some of them, they have very high minimum requirement that will let the fellow to stay another 1 or 2 years to do especially in UK. And some of them, like in the United States, where they set very low minimum requirement, could be dangerous for independent consultant to go and work independently without supervision. All trainees should be vaccinated before they start they start their training, or ICU emergency rotations, as well as anesthesia. Thank you.
Yes, we arrived to our last lecture of the session. And this is by Ms. Sama around the senior nurse in coronary care unit here, and she's also a BLS instructor. The topic is, how does COVID change my nursing practice?
بسم الله الرحمن الرحيم. شغال أمين. شغال صح؟ You can hear. بسم الله الرحمن الرحيم. Good evening. It seems I'm the last obstacle between you and your lunch, so I'll try to make this a little bit quick. My name is Samah Larimi, and I'm proudly from CCU and from the training department. I have 40 slides. No, not 40 slides. It's not 40 on that. Okay. We're going to highlight few things about how did the COVID change the nursing out of the all healthcare workers. We'll have few points about how did it change it internationally and what we have in National Heart Center. Three elements, clinically and personally, including the mental health and organizational wise. As we know, more than 50% of all healthcare workers in the healthcare systems are nurses, and COVID-19 had opened the eyes on our struggle and sacrifice and blessings even during this pandemic. Clinically, this concerned the bedside nurse and how did we became more emphasizing on the infection control measures and the practice more focus. Well, it has changed from face-to-face to more virtual and blended learning as well in some aspects. Personal from physical and mental health. Actually, I did not get clear impact on the physical health for nurses and the COVID, rather than the mental health and how did they get more with depression and anxiety. Psychosocial impact, and we know that with the social distancing, and we spent a lot of time in the hospital, and we try our best to avoid the gatherings. Everybody suffered from this, including us. Organizational, of course, with great thank and gratitude to all of their efforts with what we suffered from shortage of nurses and all the support we got from outside and even from the centers in Royal Hospital who were rotated between the departments, the need for the support and some shortage of the supplies which were filled more frequently. Supervisor charges and administrative plans for us and for the whole thing, how do we deal during the COVID, despite the fact that this is a new thing and like a shock for us, what happened, how we are supposed to continue our work like this. We have increased demand for critical care nurses. And this became very clear when we were deploying the nurses, the routine departments nurses to the critical care areas, and we needed to train them for specific things, mechanical ventilators, the importance of use the full BBE, how to stay in full BBE for the full shift and these things. Mechanical ventilators with the help of the respiratory therapists, of course. I think half nurses now, they know how to deal with mechanical ventilators because many of them were deployed to Corona or COVID departments. The equipments regarding the infusion pumps and these things, including we will have also the people or the nurses who recently joined or they were appointed or recruited only for COVID. They needed training, maybe not from the zero, but from the medium level to the critical care. The critical care nurses played a major role in this, and the in-charge ward nurses and the education department as well, to make these nurses ready to respond to all COVID patients, the stable patient and the critical care, emphasis on the infection control measures. Away from the auditing and the frequent and recurrent visit by infection control nurses, of course, we were reminding each other, reminding the doctors, even teaching the relatives and the security how to wash their hands, how to wear the mask. I'm not wearing mask because now I'm more than 3 meters from you. CPR policy and training, I would like to stop at the CPR policy and the training because I'm a little bit CPR mania. We have in each department a crash trolley. We created a mini crash trolley, a tray with, or a box in some departments where we have almost everything except the medication and the defibrillator. We have the full PPE for people who should or who are going to respond to the victims or to the patients. Usually the nurses are the first frontliners to respond to a cardiac arrest, but again, the nurses are responsible to remind whoever comes to the room to be in full PPE. And the new policy, the introduced policy for CPR, none of the healthcare workers is supposed to touch the victim before being fully in PPE. And this, we introduced also the use of the AAD, which we used to take it only in the BLS class, but we are using it. So we have a mini CPR or crash trolley in each department, and next to this in the normal departments. The COVID, they have their own full things. Okay, and the training itself was a little bit not difficult, but a lot of people, new staff, whether they are newly graduated or new staff from other healthcare institutions, they needed to have a close observation for the CPR until the other team arrived, how to do it. And this is very thankful to the CPR committee and the infection control in making these algorithms. But again, in the departments, it was our responsibility as nurses. I remember I got positive after one CPR. Why did I go there? Okay, regarding the learning and education, of course, I think in all aspects or all specialties, we have dramatically declined the face-to-face, and we are missing each other. See, only few people, we used to have 100 like here. We moved to the virtual education plus the blended learning, because some of the courses we used to conduct online, then we will have the follow-up or the observation in the department, specifically like the BLS, we used to have the mock CPR drills or the drills in the departments. The practical alternative, despite the undesirable effect, many people or many nurses, they still prefer face-to-face. On the other hand, many of them also have assumed this, the online thing also taught them how to deal with the technology. The tele-education or the telemedicine is growing very fast, and many nurses really, they are eager to learn this one. Allowed enhancement of the teaching and learning and staff convenience still not achieved in the majority, but positive feedback already acknowledged that we were still able to maintain the training education for nurses in all levels despite the pandemic. In the physical side, many of the nurses reported that they were drained out already. Anybody with charger here? Okay. Rotation of multi-specialty nurses, different departments and centers. We know that many nurses were rotated between the normal department, the COVID, the ICU COVID, even from like National Heart Center, National Diabetic Crime Center. They were of great help. ICU patients, heavy requirements, proning position, and infusions. They were heavily sedated, BBE all the time. How many of you is tolerating this full BBE? All the whole shift. Despite they were tired, but still they put their safety first. And this was emphasized also by the administration and the ward nurses. Guys, your safety comes first. Mental and psychological, and this composed most of the studies, whether in Oman or internationally. The main things the nurses suffered were anxiety, depression, and disturbed sleep. For those who are attending on Zoom, do you really get sleep, nurses? Okay, night shift. Okay, so these were the most reported things, and the thoughts of uncertainty. Social gathering maybe were the minimum thing, but the uncertainty about what's going next, first wave, second wave, third wave, am I going to get infected? Am I going to take this infection to my family, to my relatives? We are not even shaking hands there. You're not hugging We have to be in full PPE. We are missing these things, but still people, they know us from our eyes, even with the mask. So this mental really affected them. I'm sure we have a lot of assessment and evaluation of the nurses here in National Heart Center and in Royal Hospital overall, which we try to provide nurses with a lot of relaxation and other things. But still, I believe that we need more as a research or study what are the most common among nurses here and how to deal with them. Very few of the literature, because I have 22, anxiety, depression, and bad sleep habits, with maybe 1 or 2 studies showed nightmares as well. Females and nurses reported higher severity compared to the male nurses and to physician or other healthcare workers. More than 70% they were nurses compared to other healthcare workers internationally. The new employees were excited to join the job, but most were frustrated because their internship were shortened. Instead of 6 months, were 3 months with a lot of mandatory courses and mandatory job. They acknowledged the help of the preceptors and then charges, ward nurses as well. However, they felt sometimes they're, am I going to be up to your expectation, the institution expectation or not? But still they did. Most of nurses found the courage and strength to overcome the pandemic. Mainly, they reported the main thing, family and relative support, and from co-workers. We used to help, okay? You did not hear this from me. We used to encourage each other, even if we were down, even especially the people who are out of COVID, and we were always volunteering with the rotation. However, some nurses, or let's say a couple of them, new knowledge and experience with respiratory disorder patients, mainly with the mechanical ventilator. Nurses reported that they were happy. They know now about the mechanical ventilator, even without the help of respiratory therapists. They are more independent. The CVVHD, which were very common among critical care COVID patients. Physiotherapy importance. Yes, we know how important it is in the critical care. However, they realized more because now we had physiotherapists dedicated to the COVID departments, and it was really helpful. Importance of research and further studies in the field of healthcare sectors, mainly because they have seen or witnessed a lot of researches by doctors and by internationally usually. So they know now, every now and then the research or the knowledge will change. So what is my response as a nurse? What is my responsibility? Is it only to read, to make my work as evidence-based practice? How can I contribute to this? We care for ourselves, patients, co-workers, and we take responsibility to teach and train others as well, which we did mostly in our department to remind each other. Hand washing, mask, even double mask, the face shield. These all were learned, and it was there in nursing, but COVID made it more, it's like turning carbon to almas. Okay, our experience in brief in National Heart Center, the teamwork. We always emphasize on teamwork. The teamwork came in the bedside, in the training. I don't want to miss somebody, but I witnessed the struggle of Omaima. Okay, I was with her for a few months, and structured training for all comers for COVID department, critical as well as other training, staff spaces for food, which we turned the organization or the administration turned the whole center dedicated for COVID, spaces for food, relaxation, and rest, and of course, providing the psychological support by psychological team from Royal Hospital, as well as we had sufficient amount of PPE. Let's say most of the time we have this one. I did not hear anybody complain about that we had shortage of PPE after a few months of the start. Maybe at the beginning only because we are not used, but later for this more than 1 year, everybody is satisfied with that amount and the sufficient use of PPE. So the last, my safety is the priority. I think it's not selfishness, but some nurses, they used to say, we did not think that we will be in the face of the fire like this, but and we used to sacrifice, we used to give the priority to the other part, whether a patient or that. But now, if I'm not safe, they will not be safe. So proper PPE, strict adherence to infection control measures, some like here and there, the vaccine importance, and protect others as well, mainly with the visiting time, during the visiting times. It was our responsibility to maintain the visitors and attendant. My health is a priority as well. If it is a simple sneezing, don't ignore it, might be, which made some nurses freak out. Huh? sneezing, maybe I'm having COVID. It's not like that, but they are more aware with the symptoms, the changing symptoms, relaxation and sleep and meditation for some people. Doesn't work for me. Ask for help once needed. Don't say that you are not alone. You're not going through this one alone. Remember, you have your coworkers, you have your family. Wallahi, personally, during this pandemic, my family was the first support, like anything, even though they were telling me, watch out before you come to the house, because I was infected. Then the coworkers, and if you're not getting from anyone, go to the administration, to the psychological support. They are really helpful. My community is a great asset. Yes, what is this spelling mistake? Okay. Family, relatives, friends, and co-workers, despite the fact that at the beginning the community were not really understanding the severity or the seriousness of what the country is going through, but thank you very much for those who took it seriously and they cooperated like anything. Take home messages. Oh, where's the video? Okay. Knowing is not enough. You must take action. Yes, we know the nurses are struggling or they have gone through this and this and this. So what to do? According to literature, the most thing was requested is the institutional support, proper planning and action, initiatives that are highly recommended, appreciated and needed for bringing out the best of the nurses. All the nurses, most of them, they are really willing to give more instead of taking. However, not only the appreciation, but they need to be charged to be ready to give more than they do. These are only a few of my references, one or two of them from Oman. Thank you very much. If anybody has questions, okay. I think.
Thank you very much. This was very positive. Okay, may I request all the speakers, please? We have 10 minutes for questions.
Okay.
Thank you, everyone. Questions? I have just one question to so, when you said, in-person simulation is being stopped, is there any strong reason maybe for stopping the simulation? It's no contact.
So the first number one reason is
okay. Let's ask you what is the in-person simulation?
So the simulation there is multiple types of simulation. High fidelity simulation, for example, it's exactly the same as in-person simulation. So, for example, there is one person here, there's one person here. So you are like in the operating theater, you bring the operating theater to the simulation center. Then you are running a scenario, and people are there doing scenarios or doing something like technical steps, or it's called simulated patient SK scenarios. This is big. You will be very close contact with the patient or with the people who are participating. So the question first, because they need to have more evidence that this doesn't increase the risk of infection. Two, there is a lot of these require to have a lot of people inside the simulation. For example, like in high fidelity, there is almost like 7 people involved in the scenario. Maybe 5 or 7 people are outside watching. Like we did one of the simulation exit procedure. So we have an exit procedure, which is done like sometime 1 in 10 years. And people, they did 1 in 20 years, and they did 2 in 1 year. And the last one was very bad outcome. So they wanted to do simulation because it's a very highly specialized procedure that require almost like 5 subspecialties. So we were in a very huge hybrid operating theater. And then that's after the the pandemic, almost after 6 months or 8 months, where the equipment already available and everything. And the infection control only allowed to have maximum of 10 people inside. Okay. And the others are on Zoom, or they are watching outside because there is some glass there. So this is in-person simulation, and now it's back, almost all back in simulation. But in lab simulation centers, everyone has to have eye shield and this mask and gloves. So with this virtual on Zoom, so the virtual people so the virtual for technical. So what we do, how we adapt it, I will tell you from my experience. So in the virtual training, you get residents that are, we do simulation boot camp. So like 2 days a week. So there is this day, half of the residents will get hands. Half of them, they will participate in the patients. The next day, they will be opposite. But for boot camp, ACLS, boot camp, everyone did. But they, instead of coming all together, for example, today, everyone will finish prerequisite as virtual courses. Next day only become only for scenarios.
So my question to Joey, so what is your experience in drone ventilation, particularly for this subset of COVID patients that have benefit all set of patients or obese group of patients? How it has helped actually? What is your clinical experience on ventilation?
Yeah, so in our experience, so we faced that first wave, the second wave, and we don't know the second wave, whether it was second or third, we don't know. It all just came as a storm. So during the first wave, and the criteria remained the same. Anybody with PF ratio less than 150, and they're already on 10 plus P, we are giving lung protective ventilation. We decide to probe them as soon as they come. And the body habitat didn't matter. We have probed even a 200 kg patient. So the obesity, in fact, we noticed that the obese patient responded much better with probing. And in supine, it was impossible to maintain their oxygenation. The moment you probe them, they improved dramatically. The only drawback was that after 60, when you have to supine them for 8 hours.
Did you change your any mode of ventilation or the same ventilation modality?
So we were able to give even better lung protective ventilation when we were proning. Obviously, the requirement we could reduce. Otherwise, in the supine position, we went on higher peeps and all when they were in the later stages of the ARDS. So even then, we could hardly achieve any improvement in the PF ratio. But the moment we used to prone them, we used to see the benefit. But and in the prone position, then we used to come down on the ventilatory requirement. The moment we used to supine them, within say an hour or so, the requirement used to go up. So in fact, unfortunately for some patients, we did up to 10 pronings on a consecutive day. But still, when we came to the 11th day, we could not sustain their oxygenation in the supine position. So those were the stage, so they reached the stage where they are like now late stages, they are going into the fibrotic stage. And then, you are also having limited resources. You cannot continue this because the improvement started coming down, the improvement in the PF ratios. So then we had to call it a day. So those kind of dilemmas also we had, those ethical dilemmas or moral dilemmas, you see. Because we have so many patients and after 5 pronings are recommended, definitely. But there is no limit. We have done even 10 pronings for a patient. Patient is young and they would all have single organ failure. You want to do something for them, that's all. And there is nothing else after proning. We didn't have ECMO facility. So we just, and the medications, everything we have tried. So proning was the only tool which was available and we all became experts. So for us, proning was not a problem. It was just taking the decision.
Some of the patients, they responded well.
Well, yeah. But then those other issues are there for proning. You have to paralyze them. So that many days of paralysis. And with these steroids and the immunomodulation, then myopathy, then they did recover for from the ventilation for a long time. Even after you stop proning, Some of them did come down on their oxygenation status, but then myopathy was so severe they couldn't move an inch. So then tracheostomy, then prolonged length of stay. But we have had some patients who have recovered after like 2 months of stay in ICU also. So we could never give up easily on all those patients. But if they ended up into septic shock, went to high inotropic support, then later on we couldn't help them. But if it was single organ, we supported them till then. Once you tracheostomize, of course, we cannot probe them anymore. So once we reach that stage, then it's up to them. Then some of them recover, some don't.
See, this proning, there was, if you consider the ARDS network, there was some doubt. Some patients used to improve with proning, some patients never. So what is it that is specific to, from what you have heard, what is the mechanism by which the proning helps improve the PaO to FiO2 ratios and improve the oxygen ratio? Is it because of better alveolar? No, because of
alveolar recruit.
So that means the lung compliance is improved somehow in the dependent parts.
Or in the lobes, the particular lobes, involvement. So did you see there's a difference in the lobes involved with the disease? Something like that. It was always a bilateral involvement. And even if you see the X-ray that some areas are looking better, but end of the day it's been transferred into the numbers. So, and we could not do CT scans for many of our patients because the requirement was so high. But if you do CT, even in the X-ray 2-dimensional, you feel only half of the lung is full. When you do CT, you will see 75% of the lung. It's worse. It's worse. Like, X-ray looks fine, but actually, because X-ray always lags behind. Yeah, we could continue our measures.
No, but it delays.
Delays
Your
also,
clinical signs are earlier than the actual radiological signs, always. No, clinical improvement is much better.
Exactly. The late stage. Yeah, we had to take a complete history system. You cannot just rely on the X-ray finding. You have to see your improvement in the blood gases. And then only you can say that, okay, this X-ray is corresponding to the improvement. Otherwise, if the X-ray improves, the numbers don't improve, still it is. So we have to take everything into consideration. And then we have to look at other causes. Like the patient is still not improving even after your recruitment maneuvers. You have opened up all the alveoli, you believe. Then you have to look at whether it is perfusion problem. Because PE was very common in this patient. Again, we could not do, and even your echo will not tell you whether it's a massive, only massive PE will tell. Segmental and all, how you think that? So then we used to give empirical anticoagulation to this patient.
Sally, you said negative suction, to the oxygen. Now that's a very fine balance, isn't it? The flow, the speed flow you normally give is hardly 10, about 100 ml, 50 ml, especially I'm speaking about PF. So when you apply a negative suction to the exhaust, that is going to increase your plasma leak. So why did you say that 10 centimeters of, is it 10 centimeters of water or 10 millimeters negative pressure?
No, it's millimeter of water.
Yeah. 10 millimeters of mercury, negative pressure, when your speed flow is very limited, how can it be safe?
See, that maybe that scavenger what we put it in the oxygenator is not too, it's nothing to related to the how much sweet gas we are giving. Sweet gas, no matter what, how you get this lower, like lower amount or higher amount, it doesn't match with how much we are taking out. I mean, there's no relation in that because that oxygenator, if you are using other oxygenator, we different that big oxygenator. So if you are using that, for example, neonatal oxygenator, you are giving 100 ml to be the same amount for giving 1 liter, for example, 2 liter for the bigger oxygenators. So because also that depends on the flow, so how much it flow. For pediatric, we have flown 100 ml for adults, measuring by liters.
For patients who have been prolonged ventilation and they were discharged, how much they remember? Was it a totally blank thing or anything they remember?
That's very interesting question. We had one patient.
Yeah.
He was an Indian expatriate who was with us for 2 months in the ICU, and he almost had given up on it. But somehow, only good thing was his brain was totally dead after tracheostomy. He was totally with us. He was able to recognize everything, even like eat with that, but he was ventilator dependent for a long time. Totally myopathic, 60-plus-year-old man. Myopathic, like he was totally flaccid, you can say. But somehow with physiotherapy, he improved. And he walked and came to us to meet us after 3 months. Now, when we asked him, he didn't have memory of anything untoward, like we poking him or anything. He does remember, of course, somehow he remembered only the good things, somebody bringing tea for him, somebody making him stand or doing physiotherapy for him. So it was like, I think all these drugs are our anesthetic drugs do wonders sometimes. They really help them to forget all the nasty things that we do. Exactly, they remember only the good things. Or probably when the outcome is good, they automatically they forget everything. We have had a couple of patients who came back walking to us and they had no complaints.
So what was the sedation?
Always midazolam and fentanyl. And sometimes, of course, we had to go to morphine. We kept alternating. Sometimes they
dreams,
antigrade amnesia, somehow. And propofol, we use a lot of propofol also. Every type of sedation we use. In fact, we paralyzed them for so long. But still, nobody really, at least nobody complained. Maybe they were so happy.
You mentioned a nice study in awareness.
Yes.
Yeah.
So just one my final word, Department of Thank you very, very much for this gathering. Special thanks, I should say, not because he is just because he is my old friend. 20 years of friendship. So